Welcome everyone. Thank you all for joining us for this today's CME. It gives me immense pleasure to introduce our next presenter, Dr. Manjit Kaur. She is professor in Department of Histopathology, PGIM, Chandigarh. She has a Commonwealth Scholarship for Masters in Molecular Pathology and Genomics at London School of Medicine and Dentistry. She has been awarded with V.R. Karnarkar Award for Best Published Paper. She has special interest in oncopathology with more than 200 publications in national and international journals. Today, she will enlighten us on the topic of advances in breast pathology. Now, without any further delay, we turn to Dr. Manjit Kaur. Welcome, ma'am. Please share your kind views with us.
Okay, good morning and thank you for kind introduction and thank you Manjit for having us here. So I'll share my screen. Okay, can everybody hear me and see my screen?
Yes, ma'am.
Yes, ma'am.
You're audible and screen is visible, ma'am.
Okay, so the topic which I'm going to discuss today is advances in breast cancer pathology. So the outline of my talk will be, I'll discuss the conventional prognostic or predictive biomarkers which we have been using in breast cancer till date. I'll cover molecular classification of breast cancer, which has been there for past few years now, and with special reference to triple negative breast cancer, which is the most heterogeneous of all the subtypes. And now we have triple negative breast cancer as a high grade triple negative breast cancer and low grade triple negative breast cancer. And we'll discuss new biomarkers for newer targeted therapies. And I'll also touch upon tumor infiltrating lymphocytes and role of immunotherapy in breast cancer. Okay, so as we know, as pathologists, our role is not only in making diagnosis of breast cancer, but we have to provide information on the prognostic factors also. So we have to tell them which factors, which morphological or gross factors will convey the clinician that this is going to behave better or it is going to behave in an aggressive manner. In addition to prognosis, we'll also give information about predictive factors, which tell the clinician that these particular breast cancers are going to respond to this particular therapy. So what are the prognostic factors for invasive breast cancer, which we have been using for past few years now? So tumor size is the most commonly used prognostic factor, in addition to histological grade, histological type, and axillary lymph node status. So we know the larger tumors, they behave aggressively or they have a high mortality in breast cancer as compared to the early breast cancers or the tumors which are smaller in size. Similarly, for histological grading, the poorly differentiated or grade 3 tumors behave aggressively as compared to grade 1 or grade 2 tumors. And you know, we use Bloom and Richardson method of histological grading of breast cancers. Now, since we are typing these breast tumors based upon histology also, so morphological variants also have important significance in conveying the prognostic information. So for example, tubular carcinoma, cribriform carcinoma of the breast, pure mucinous carcinoma of the breast, adenoid cystic carcinoma, and juvenile secretory carcinoma of the breast, they have a very good clinical behavior. So whenever you find classical features of these subtypes, you should call them by their name and you should not call it IDC grade 1. Okay, because IDC grade 1 versus tubular, cribriform, pure mucinous, they have different prognostic implications. And similarly, the tumors which are associated with poor prognosis include those which have signet ring morphology or like a pleomorphic variant of invasive lobular carcinoma and inflammatory carcinoma of the breast. Other tumors like metaplastic carcinomas, for example, squamous cell carcinoma or carcinomas with neuroendocrine features, they have prognosis similar to IDC NOS. So morphology also plays an important role in conveying the prognosis. So we should diagnose them accurately. And the most important prognostic factor which clinicians have been using for deciding their treatment protocols is the axillary lymph node examination. So we tend to see macrometastasis, which are more than 2 millimeter in size. We also see micrometastasis, which is 0.2 millimeter to less than 2 millimeter in size. And rarely there was a lot of discussion in previous years about isolated tumor cells or occult metastasis, for which you have to do multiple serial sections or even take help of immunohistochemistry to report these. But now there is no significance of these two categories, isolated tumor cells or occult metastasis, because even after such a hard work, you find these also, these are still treated as N0 breast tumors. Okay, so but we should always report macro and micrometastasis, and it been divided into different categories depending upon the number of the lymph nodes involved. So in addition to presence or absence of metastasis in the lymph nodes, we should also give information how many nodes are involved out of how many which have been sampled, because this gives us information on a 5-year survival rate. So as the number of positive lymph nodes increases, the survival rate is decreasing. So in addition to these morphological and gross factors, what we have been doing for a few years now is giving information on predictive markers. For this, we have been reporting ER/PR, that is estrogen and progesterone receptor, because this gives us an idea about how they will respond to anti-estrogen treatment. Similarly, we are doing HER2 immunohistochemistry, for which they give an anti-Herceptin or a Herceptin treatment or anti-HER2 other targeted drugs. And in addition, we are also using Ki-67 index, which is a proliferation marker. So it gives a clue how these patients will respond to chemotherapy. So for ER/PR, we are using LRED scoring system, and it should be a nuclear positivity. So you give a score of intensity and you give a score of a proportion of tumor cells which are expressing it. And the maximum LROD score is 8. So for this, you have to tell them whether it is high ER positive or it is a low ER positivity, because low ER positive tumors will behave slightly different than those tumors which are presenting with a strong ER expression. Similarly, for HER2, we have to take care whether it is strong membranous positivity, then you can report it on immunohistochemistry. But if it is less than 3+ complete membranous positivity, you call it equivocal, and you should take help of fluorescence in situ hybridization, so which will show amplification, because these are costly treatments. So you should be very sure whether HER2 is actually amplified or not. Out of these, the Ki is the most controversial predictive marker which we use, but clinicians are using this Ki index for deciding whether they have to give chemotherapy, adjuvant chemotherapy or not. It is controversial because there is no cutoffs available. Though there are cutoffs, but these are not very significantly related with this disease survival or overall survivals. So cutoff which has been reported in literature is like less than 14% will be taken as a low Ki index, and more than 14% will be taken as a high Ki-67 index. So this gives a clue whether the patient is going to respond. So higher proliferating tumors, they respond better to chemotherapy as compared to the lower Ki index tumors. So in addition to these IHC markers, clinicians have been using these gene expression signatures also. So why they use these gene expression signatures? Because they have to take decisions for chemotherapy, especially in the ER positive and HER2 negative breast cancers, and also for node negative breast cancers. But now they are trying to implicate these signatures for lymph node positive, especially for 1 to 3 lymph node positive breast cancers. So the most common, or which are FDA approved and which are in clinical practice, are Oncotype DX and MemmaPrint 70 gene signature. And out of these, Oncotype DX is most commonly used. So what is Oncotype DX? It's a 20 gene recurrence score assay. Out of this, 16 genes are cancer related genes. If you can see the list of these genes, most of these are associated with proliferation, estrogen receptor, HER2 receptor, and factors which promote invasion into the stroma. And then there are few immune markers also. And there are 5 reference genes. So based upon this assay recurrence score, they divide the patients into 3 risk categories: low, intermediate, and high. So what does this recurrence score assay predicts? So it predicts the risk of distant relapse at 10 years for ER positive and no negative tumors. And it also tells the clinicians that this particular patient or the patients who are in high or intermediate risk, they need adjuvant chemotherapy and they will be benefited from chemotherapy in addition to tamoxifen, which they give for ER positive tumors. So in addition to Oncotype DX and MammaPrint, there are few others available like PAM50, Prosigna, which in addition to giving a risk of recurrence score, they also tells about the molecular subtypes, which we'll discuss in a later slides. And then we have breast cancer index, which is a 7-gene panel, and we have an EndoPredict, which is a 11-gene panel. But out of these, most commonly used is the Oncotype DX. Okay. So what are the clinical applications of these gene expression signatures? So they tell us whether these patients will respond to conventional chemotherapy or not, whether they should suppress or they should increase the adjuvant systemic therapy in patients who are positive for estrogen receptor, and also to give estrogen therapy in greater than 5 years duration, because normally they give tamoxifen for 5 years in ER positive tumors, but if the recurrence score is high, they extend this tamoxifen beyond 5 years. And similarly, PAM50, as I said, and Blueprint, it also gives us a clue about the molecular subtypes, which helps us in assessing the prognosis. Okay, but these are very costly and they are centralized. You have to send them to a particular lab where they will do these tests, and it costs, I think, huge amount of money, around 2 lakhs for patient. So what is a poor man's cost-effective signature, which is IHC4 plus C? So IHC4, which we have been doing for ages now, that is ER expression, PR expression, HER2 expression, as well as Ki67 index. So clinicians combine these 4 parameters, which we give to them, with the clinical information like status of node, size of tumor, grade of tumor, and age of the patient. And this IHC4 plus C signature gives similar information what is given by Oncotype DX. So in India, most of the clinicians are using our pathological parameters, which we provide them for deciding which chemotherapy has to be given to these ER positive patients. So despite we have been giving this information for prediction of response to therapy, there is a need for classification or molecular classification of breast cancer. So routine clinical management of breast cancer relies both on clinical as well as prognostic factors. But however, these factors, they are insufficient to reflect the whole clinical heterogeneity. Because you have seen a similar patient, some of these patients respond better, some of these patients respond badly. So there is something happening at a molecular level which is controlling this response to the therapy in different patients. So as we know, breast cancer is a complex genetic disease which is characterized by a accumulation of multiple molecular alterations. And now we have very advanced genomic research techniques and molecular technologies. So people have tried to look at a molecular level in breast cancer. So first classification or a molecular classification of breast cancer was given by Peru et al. In year 2000 based upon a gene expression profiling. So you can see the heat map on the left side, but same gene expression profiling has now been converted to a surrogate immunohistochemical classification using immunohistochemistry by the pathologists. So this gene expression profiling classified the breast tumors into ER positive and ER negative. ER negative tumors were classified into basal-like, normal breast-like, and HER2 positive breast cancers. But since this was in 2000, so normal breast category does not exist now. Probably they thought that there was a mixture of lot of normal breast tissue in this gene expression profiling, and basal-like they have now categorized into a triple negative breast cancer subtype rather than a separate subtype. So in addition to this classification based upon gene expression profiling, there is a cytokeratin classification also. So this tells us about the origin of the tumors. So we know that the luminal epithelial cells, they are positive for CK7, 8, 18, and 19. And the basal epithelial cells, they are positive for CK5, 6, 14, and 15. So from this has come the classification of a luminal subtypes or the basal subtypes. So based upon these gene expression profilings and based upon immunohistochemistry, taking into account the ER/PR HER2 status as well as the cytokeratin status, the breast cancer is now classified into two broad groups, hormone receptor positive and hormone receptor negative. Hormone receptor positive is further classified into luminal A and luminal B, whereas negative ones are categorized as HER2 positive and triple negative breast cancer. So of these, the luminal subtypes, they are constituting around 67%. That is the major chunk of the breast cancers are of luminal subtype. As I already said, they express hormone receptors. They are luminal, show positivity for luminal markers, that is cytokeratin 8, 18, and they express the genes which are related to estrogen receptor. They have very few p53 mutations, which is usually seen in ER negative groups. So out of these luminal subtypes, we have luminal A and luminal B subtypes. Luminal A subtypes are those which are showing high expression of ER, PR, and they are negative for HER2. In contrast, the luminal B is classified where you have low to moderate ER expression in the tumors. PR expression may be seen or it is absent. So on the right hand side, if you see two boxes, there are two ways of classifying luminal B breast cancers. So one is ER/PR positive, HER2 negative. However, the proliferation index is more than 14%. And the second way of classifying luminal B breast cancer is ER/PR positive, any KI, but it is HER2 overexpressing. So luminal B category of tumors are either ER/PR positive with high KI index, or these are ER/PR positive tumors with HER2 overexpression, coexisting HER2 overexpression. So these luminal B tumors, they behave aggressively as compared to luminal A tumors. So whenever you report your ER positivity, it should be very accurate, because low ER positivity and high ER positivity makes difference in the classification and further in prognosis. The HER2 subtype is classified as expression of HER2 on immunohistochemistry. And most of these tumors are aggressive as compared to the estrogen receptor or hormone receptor positive tumors. They have high proportion of p53 mutations, and mostly they are grade 3 tumors. And they respond to the targeted therapy, of course, that is anti-HER2 therapies. But they also show higher sensitivity to the conventional chemotherapy, which is anthracycline or taxane based. But now when we are using anti-HER2 therapies, there have been reports which show evidence of resistance to anti-HER2 therapy. And this is because of activation of the different pathways. And the third group is the triple negative breast cancer, which is the most heterogeneous group. So current treatment for triple negative is only chemotherapy, because there are no targets available which can be targeted. So initially they respond to chemotherapy, but later on they develop metastasis or relapse, and they're usually associated with short survival. So because of this heterogeneity, now different studies are going on to decipher this heterogeneity, why these tumors are not responding to therapy, why they recur again. So these molecular classifications have been done at the level of transcriptome, proteome, genome, even epigenome, even immune markers, and the BRCA-related genes, which people have been trying to use for many years now. So the transcriptome profiling of triple negative breast cancer was given in 2010, exactly 10 years after the molecular classification of the breast cancer as a whole. And it was given by two groups. One is Peru et al. And second is by Lehman et al. So what they did, based on gene expression profiling, they divided the breast cancer into basal-like 1, basal-like 2, immunomodulatory, mesenchymal stem cell-like, and luminal androgen receptor subtype. However, after a few years, Lehman et al. Realized when they did this gene expression profiling, they did not isolate the tumor population. They did not take a pure tumor population because they used a whole tumor sections, which included the tumor stroma also and the tumor immune cells also. So later in 2016, they repeated their gene expression profiling by microdissecting the lesion into basal-like 1, basal-like 2, mesenchymal 6 subtypes. They have classified it into 4 subtypes. Okay, they removed the immunomodulatory and the mesenchymal subtypes, thinking that probably these were contributed by the stroma, tumor stroma, rather than the tumor cells per se. So coming to each of these groups, first is the basal-like. So it is termed basal-like because it expresses the basal markers, that is CK56414. And the reason is it develops from the progenitor stage of memory epithelial cells, which I'll show in the next slide. These are negative for PR3 mutations and BRCA1 mutations, and the most genomically unstable Okay, so continuing to basal-like 1, it is characterized by expression of cytokeratin 5, 6, and 4, 14. And as I said, it's rich in mutations in TP53 and BRCA1 pathway. Whereas in contrast to basal-like 1, basal-like 2 tumors, in addition, they show increased expression of EGFR. And they also show alterations in MET and WNT pathway. Now coming to the mesenchymal stem cell type, or which was previously also known as mesenchymal or a
Miss Shama, can you see what has happened?
I think it's a problem on end of Dr. Manjit.
Okay.
Her internet connection is not stable.
Okay.
It has happened second time now.
No problem. It's a technical issue. I know.
Yeah.
No problem. Let's go.
Yes. Dr. Amanjeet. Dr. Amanjeet. Dr. Amanjeet, please unmute your video, audio. Please unmute your audio. And you can, hello.
Hello, yes. Can you hear me
Madam,
now?
you can, yes, we can hear you. If there's some internet problem, you can just switch off your video and put your presentation, share your presentation and talk audio. You can put off your video. Yeah.
Okay. So, I mean, you were hearing me till which slide and how much time I have?
Ma'am, you can go ahead. We have time.
Okay.
Yes.
Okay, so I was talking about subtyping the triple negative breast cancer using immunohistochemistry. So people have done it using what we say gene expression profiling, but we tried this using immunohistochemistry. So what we did it, we used CK5, 6, and 414 for classifying into basal-like 1.
Ma'am, you have, sorry ma'am, sorry to interrupt you ma'am.
Yes.
Ma'am, you have not shared screen. Sorry, apologies.
Okay. I don't know why it stops sharing itself. Can you see it now, my screen?
Yes, ma'am. You can put it on slide.
Yeah.
Slideshow.
Okay. Sorry about that. Okay. So triple negative breast cancer using immunohistochemistry can be classified into basal-like 1 and basal-like 2. So we can use cytokeratin 5, 6, and 414 for basal-like 1. And if they express EGFR, they will be categorized as basal-like 2. Similarly, mesenchymal stem cell type or claudin low type, they show down regulation of claudin 3 and 7 and E-cadherin, and they show positive expression for vimentin. As I said, they will show down regulation of cell-cell adhesion junctions, but they will show evidence of epithelial mesenchymal transition. Similarly, for luminal androgen receptor type, they are positive for androgen receptor. So in our cohort, if we see, the most common was the mesenchymal subtype, followed by luminal androgen receptor subtype, and then basal-like 1. And we had only 4 cases of basal-like 2 subtype. So this can be doable using immunohistochemistry. And in addition to the IHC pattern, they also show some morphological features which can give you a clue that this could be this subtype. So on the A picture is showing luminal androgen receptor subtype, where you see tumor cells are having abundant eosinophilic granular cytoplasm or some vacuolated cytoplasm. So when you see tumor cells with abundant eosinophilic cytoplasm, that is the apocrine morphology, you should think of luminal androgen receptor subtype. Then panel B is showing the tumor cells with very less desmoplastic stroma, but lot of lymphocytic infiltrate. So this should strike you that it could be probably a basal subtype. Whereas the mesenchymal subtype is showing spindly. So most of the metaplastic carcinomas were categorized either as mesenchymal subtype or the mixed subtype, which showed features of both basal and the mesenchymal subtype. So if you see the clinicopathological features, the androgen receptor positive triple negative breast cancers were seen in elderly. They had a low KI index. However, they showed 60% cases showed a lymph node metastasis. Whereas the mesenchymal subtype is seen in a younger females, have a high KI index and very low lymph node positivity status. And so is for basal-like subtype, which also shows high KI index and very low positivity for lymph node metastasis. So this was about high-grade triple-negative breast cancers. Now there is a category which is known as low-grade triple-negative breast lesions also. So these have been further classified into low-grade triple-negative breast cancer neoplasia family. So it means the genetic landscape is same as what we see in a high-grade triple-negative breast cancer. Only thing is morphologically they are low-grade tumors. And this includes microglandular adenosis, atypical microglandular adenosis, and actinic cell carcinoma. Then second category in low-grade triple-negative lesions is a salivary gland-like tumors of the breast, which includes all spectrum of salivary gland tumors, and they are all almost similar to what we see in the salivary glands. And the third category is low-grade variants of metaplastic breast carcinoma and a newly described solid papillary carcinoma with reverse polarity. So this is low-grade triple-negative breast cancer or breast neoplasia family. So it means it has a genetic feature same as high-grade triple-negative breast cancers, but morphologically it shows a low-grade morphology. So in this category, we have microglandular adenosis, which is a glandular or a small glandular or rounded proliferations which were lacking myoepithelial cells. But initially they were categorized as a benign reactive condition, but now it has gained importance because of the spectrum of lesions which can be seen in its spectra. Like we can see atypical microglandular adenosis where you see proliferation of cells within the lumina, and then it can transform to a high-grade triple negative or invasive breast carcinomas also. And the second category is actinic cell carcinoma, which is characterized by diffuse serous differentiation, which is depicted by presence of these eosinophilic secretions, or you can confirm it by a lysozyme expression. So similar to microglandular adenosis, these actinic cell carcinomas can also transform to high-grade triple-negative breast cancers. So these are low-grade triple-negative breast cancers, which can convert to high-grade triple-negative breast cancers, and the molecular landscape of these tumors is almost similar. The second category, as I said, is a salivary gland-like tumors of the breast. These all are triple-negative breast cancer. Morphologically, they are similar to what we see them as in salivary glands, like adenoid cystic carcinoma, secretory carcinoma, polymorphous carcinoma, mucoepidermoid, and adenomyoepithelioma. And these have their classical fusions, which are also noticed in the salivary when they are present in the salivary gland. The third category was low-grade variants of metaplastic breast carcinomas. So as we know, metaplastic breast carcinomas are dominantly high-grade, like they look like sarcomas, they look like squamous cell carcinomas or chondromyxoid tumors. But there are two variants which are categorized as low-grade variants of metaplastic breast carcinoma. One is low-grade fibromatosis like metaplastic carcinoma, where you see bland spindle cell arrangement of the tumor cells in a markedly desmoplastic stroma. So you may not appreciate these epithelial cells on H&E stain, and if you do cytokeratin immunostain, which is in the lower panel, you can highlight these tumor cells embedded within a desmoplastic or a fibromatosis-like stroma. And similarly, low-grade adenosquamous carcinomas, you see clusters of squamous cells in an abundant desmoplastic response. So these also come under a low-grade category of a triple-negative breast cancer. And this is the rare variant which only few reports are there in the literature, which is solid papillary carcinoma with reverse polarity. So in contrast to solid papillary carcinoma, which we know is ER positive, this is a triple negative breast cancer. So this is characterized by abnormal apical nuclear localization. That is why it is known as a carcinoma with reverse polarity. And this resembles the tumors of tall cell variant of a papillary thyroid carcinoma. But this is extremely rare and only few case reports are there in the literature. But if you see, you tend to recognize this because normal solid papillary carcinomas of breast are ER positive. But if you see with reversal of polarity, then these are categorized as triple negative breast carcinomas. So this is how the spectrum of low-grade and high-grade triple-negative breast carcinomas is there. But these low-grade can progress to high-grade triple-negative breast carcinomas. So this you can remember, you may see both low-grade and high-grade in a single section also. So that was about triple-negative breast carcinoma. Now I'll quickly cover what are the new targets for therapy. And these targets, probably they are looking for the triple negative breast cancers where there are no existing targets, or for the patients who are ER positive and have become resistant to the ER targeted therapy. So of these, the two main common which are already in clinical use is the BRCA1 mutations, and second is the PI3K pathway alterations. So BRCA1 mutations, as you know, are associated with hereditary breast cancer, which constitutes only 5 to 10% of the breast cancer. So function of BRCA1 is to repair homologous recombination repair. But when patients are showing BRCA1 mutations, these patients are deficient in this repair. And so if there is this DNA repair is not happening, this leads on to genomic instability within the tumors. So BRCA1 mutations you usually look for by using sequencing techniques. However, this is seen in hereditary breast cancer, they say, but 90% of our breast tumors are sporadic breast tumors, which are not showing any familial or hereditary component. But these tumors also show loss of expression of BRCA1 at the level of mRNA or at the level of protein. And mostly this is seen in a triple negative breast carcinoma. So you can use IHC for showing the loss of expression of BRCA1. And the mechanism for this protein loss in absence of mutation is by a epigenetic phenomena. And they say the acquired methylation of the BRCA1 promoter leads to downregulation of this BRCA1 protein or mRNA expression in these tumors. So what is the significance of noting down the BRCA1 mutations or BRCA1 IHC? So if you don't have these two, then pathologists have coined the term BRCA-ness. So BRCA-ness is the morphological features, as I already told you in my previous slides. So there are certain morphological clues like sheets of tumor cells, very little desmoplastic stroma, lot of inflammatory stroma, and some of the tumors which show a central large fibrous scar are mostly like a basal-like, and they give a clue that these may be BRCA deregulated. So clinicians have been using all these three parameters to give a BRCA1 targeted therapy. And what is that? So that is PARP inhibitors. So in BRCA1 deficient, BRCA1 mutated, or the tumors which are showing BRCA-ness, the clinicians are using PARP inhibitors, but it is important to look at the morphology to tell whether these patients will respond to PARP inhibitors or not, because these are highly toxic drugs. The second target which is being used in clinical practice now is the PI3-AKT-mTOR pathway. So there are significant molecular alterations which are acting in this pathway. So they can be mutations in PIK3, they can be PTEN inactivation, AKT1 mutations. And since this pathway has an important role in growth and proliferation, angiogenesis, and metabolism of the tumors, so any of these mutations can lead to resistance to the chemotherapy or estrogen receptor therapy. So the spectrum of PIK3 mutations in breast cancer has been variable, and it varies according to the subtype of breast cancer. They are more frequent in hormone receptor positive tumors, less frequent in HER2, and least in triple negative breast cancer. And most of these mutations, if you see, are on exon 4 and exon 9 and exon 20 of the PIK3 gene. So now there are commercially available kits which targets only these 4 or 5 hotspot mutations, which can be easily done. So if you see a distribution of these mutations in a triple negative breast cancer, majority of the mutations were noted in the luminal androgen receptor subtype. So this is similar to what we see in a hormone receptor positive tumors, where we see higher PIK3 mutations, and similarly in triple negative, the androgen receptor subtype shows higher incidence of PIK3 mutations. So why do PIK3 mutations? In 2019, the FDA has approved a drug for treating the patients who have PIK3CA mutations in hormone positive breast cancer. And since a subtype of triple negative breast cancer, especially the luminal androgen receptor subtype, is also showing these mutations, these drugs can be used for this triple negative subtype also. And since they have approved the drug, they have also approved a companion diagnostic TheraSkin, which is a real-time PCR-based kit, by which you can look at the PIK3 hotspot mutations, both in the tissue specimens as well as in a circulating tumor DNA, if you don't have a biopsy in a relapse or recurrent setting. So this is the spectrum of mutations which are under study. PIK3, mTOR, and DNA repair targeting agents, they are already in clinical practice, while the remaining, they are under investigation. Okay, the last part of my talk is about the tumor microenvironment. As the tumor cells are playing important roles, so is the tumor microenvironment. And what do we have in the microenvironment? We have fibroblasts, myofibroblasts, immune cells, angiogenesis, extracellular matrix, remodeling. So all these factors are playing a lot of significant role in tumor progression. So of this, what is now important in clinical practice is the lymphocyte infiltration. So what is TILS? These are tumor infiltrating lymphocytes, which are lymphoid cells, and they are present in the tumor stroma, and they reflect the host immune response against the tumor cells. So higher the amount of the tumor infiltrating lymphocytes, the better is the response. So they act as a prognostic markers. Okay, so there are ways to evaluate these tumor infiltrating lymphocytes. First, you have to define which area you have to look. You have to avoid the area of necrosis. Only look in the tumor area. Do not look at the periphery of the tumor. Do not look into the central fibrous scar. Okay, so when you have decided what area you have to look for, then you look for your TILS. They should be present in the stroma only. Some of the times you see the tumor infiltrating lymphocytes admixed with the tumor cells. You have to exclude those. So only stromal tumor infiltrating lymphocytes are to be taken into account. Do not include granulocytes or the necrotic areas. Only lymphocytes and plasma cells, they constitute tumor infiltrating lymphocytes. And then you report your percentage of TILS as a percentage of the stroma containing these TILS. So this can be easily done on routine H&E stains. The next important is immune checkpoint therapy, that is PD-L1 testing, which these people are now using for triple negative breast cancer as a first line therapy, which triple negative breast cancer, which has metastasized. So they are using it as a first line therapy. So for assessing PD-L1 in breast cancer, the SP142 is the FDA approved clone. You have to do it on an automated Ventana machine. So any percentage, more than 1% immune cell positivity will be taken as positive for PD-L1. So you have to be very careful what you are assessing it. You should not assess macrophages or necrotic areas because they will give a false high PD-L1 scoring. So only lymphocytes and plasma cells need to be scored. So the first line drug, as I said, PD-L1 inhibitor is now in clinical use, and you have to do PD-L1 IHC using SP142 clone, and you have to score only immune cells. Tumor cells are not to be scored for breast cancer. So that was my last slide. So what is the take home message? That we need to understand the biology of tumors, and we have to develop the ways to specifically attack these processes. So in the end, our aim is to look for different therapeutic targets to treat the cancers which do not have therapeutic targets at present, or the tumors which have become resistant to their previous therapies. So thank you very much. So this is our breast cancer team in PGI. So it includes pathologists, research fellows, basic scientists, radiologists, and surgical oncologists. So thank you. Thank you for patient hearing.
Thank you, ma'am. Thanks for the detailed and wonderful lecture. This lecture was good for the beginners as well as for the researchers. You have covered all the aspects. I think you have not left a single thing about the carcinoma of breast. And now house is open for the queries. I request participants to unmute yourselves, and you can ask any question. You have chance to ask your queries now. You can unmute yourself and ask. We'll wait for 2 minutes, then we'll proceed further for the next lecture. Or either you can put your question in the chat box.
Yes, madam, that is better because most
Yes.
of them does not have the right to unmute themselves. So,
Okay.
any questions, please put it on chat box.
We can put, yes. Question can be entered in the chat box. In the meantime, I want to ask one thing, ma'am. Ma'am, you
Yes.
have, ma'am, how we can differentiate? What is the meaning of occult carcinoma and isolated? Means, I think for me it was same, but you have said that these both are different entities.
So isolated tumor cells you can see on morphology. So
Yes.
occult is which are not visible on H&E stain, you have to do serials and you have to take help of immunohistochemistry. So that's the difference. But now they are clubbed together and they have no significance. So no need to do any hard work finding them.
Okay, ma'am. Okay, ma'am. Okay. Thank you. And there was one more interesting part, ma'am. Solid papillary carcinoma with reverse polarity. That was very nice slide, and that was very informative. Actually, I'm very much interested in papillary carcinoma, so it was a blessing for me. And then I want to ask one more thing: is there any correlation of human papilloma virus with this carcinoma breast?
So I don't think so. Anybody has reported HPV in breast carcinomas, though they have reported in head and neck and even lung tumors also, in addition to, of course, cervix. But I'm not aware of HPV association of HPV with breast carcinomas. Mostly they are seen in association with squamous cell carcinomas. For probably we don't see much squamous in breast. So metaplastic squamous is rare. So I don't think so. There should be any association.
There's a question in Q&A, Dr. Manjit.
Okay, I'll check. Yes, ma'am, there is question from Dr. Shalu Kapoor. What is the role of liquid biopsy in breast carcinoma?
Yes, I think that's a very good question. So as I said, in a setting of a relapse or a recurrence, when patients, it's presenting at a metastatic site. So breast carcinoma has been treated by mastectomy. Now patient presents with metastasis either in the bone or in liver or in lung. And it's at a position that you cannot rebiopsy it. So in those cases, the liquid biopsy plays a role because the tumor is already metastatic. So there are high chances of finding the tumor DNA in the cell-free DNA. So most of the people are asking for PIK3 mutations in cell-free DNA rather than going for a rebiopsy in the relapse setting. So it has a potential in breast carcinoma also.
Okay, thank you. Yes, anyone else? I think there's no more question. And thank you, ma'am. Thanks for this wonderful talk and giving your time and sparing your time with your busy schedule. And that was really a very wonderful lecture and helpful for all the participants. From the again, I repeat, from the beginners to the researchers. Thank you, ma'am. Thank you very much.
Thank you. Thank you very much.
Thank you. Bye. Yes. Now moving forward to the next session, I request Dr. Manjit Kaur, Assistant Professor Pathology, to introduce our next speaker, Dr. Soumya Ranjan Malik, Associate Professor, Department of Pathology, All India Institute of Medical Sciences, New Delhi. Over to Dr. Manjit, please.
Thank you, Dr. Manjit. It's my honor and privilege to introduce our next speaker for today, Dr. Soumya Ranjan Malik, who is Associate Professor in the Department of Pathology, All India Institute of Medical Sciences. Sir has special interest in lymph node biopsies, lymphomas, and the bone marrow biopsy. He's also an international ICMR fellow. He has various achievements like various honors and achievements in his academic kitty. He has more than 70 publications in the national and the international journals and has delivered numerous lectures on the international and the national forums. We would like to enrich ourselves with your knowledge, especially on a topic which is of very relevant in day-to-day life. Sir will teach us about the mimics in the lymphoma. We welcome you, sir.
Thank you, Dr. Kaur, for inviting me. Am I audible to all?
Yes, sir.
Is my screen is visible?
Yes, sir, it is visible.
Okay. Thank you, Dr. Kaur, for inviting me this lecture. I'm always happy to teach about lymphomas. It is my passion. So today's topic is mimickers of lymphoma. So it's basically the newcomers who get always confused with whether to call lymphoma or not lymphoma. Okay, so I'll divide my lectures in 4 sections, like each topic, what are the topic, there are a little bit of introduction, so what's the etiology, what's the pathogenesis, then I go to individual entities. So mimickers of lymphoma, so what to call it? Is there any name? Is you can call it atypical lymphoproliferation. When there is a doubt what to call, is there any name can be given to it? Yes, you can call it atypical lymphoproliferation when you are in doubt whether it's a lymphoma or not lymphoma. So what is atypical lymphoproliferation? It is distorted lymph nodal architecture, but the histology falls short of the criteria for a malignancy. You are saying, yes, this is not a normal lymph node, but yes, it's not a lymphoma. You can call it atypical lymphoproliferation. There's no such a unifying classification. If you go to WHO, it is basically of a malignancy, so they don't talk much more about atypical lymphoproliferation. Many of these uncommon lymphoproliferation are basically abnormal immune response. So what is basically a lymphadenopathy? What is atypical lymphadenopathy? When you call a lymphadenopathy, any persistent lymphadenopathy without spontaneous regression for within 6 months. What is significant again? Like lymph node more than 2 centimeters in size, any supraclavicular or epitrochlear location, generalized lymphadenopathy associated with organomegaly or systemic symptom. No, not a single criteria. You cannot take a single criteria. So what I like for the newcomers, or what we prefer at AIIMS Delhi, so at least 3 parameters the pathologist must have before reporting any lymphoma cases, whether it is a generalized or localized, whether there is a B symptom present or absent, what's the duration. All 3 are very closely related to call a lymphoma or not a lymphoma, at least these 3. Generalized, I'm repeating once again, generalized or localized, what is the duration of the lymphadenopathy, whether there is a B symptom or not, whether there is a hepatosplenomegaly. So
yes, good morning.
Yes.
बस सर बढ़िया चल रहा है, आप बताइए. हाँ बोलो ना, वेबिनार चल रहा है, बोलो.
Okay. No single criteria is available to establish evolution of a malignant lymphoma. So what are the etiologies? So it could be starts with infectious, it could be primary immunodeficiency, it could be autoimmune, it could be drug induced. But most of the time, what you in the day-to-day clinical practice, what you feel, most of them are either related to infectious, mostly viral. Second is your autoimmune lymphadenopathy. Very rarely you find with this drug induced, and this uncommon. So if you go one by one, start with infectious, then this unknown and the autoimmune, they go side by side, then forms the drug induced, then the primary immunodeficiency. So among the infectious, maybe bacterial, maybe viral. So mostly it is the viral one which confuses, and the most ubiquitous virus like Epstein-Barr virus. Everybody has Epstein-Barr virus. So when it will be activated, it may causes any lymphadenopathy, lymphoma, acute viral infection, may confuses. So what is the pathogenesis basically for this any lymphoma or any atypical lymphoproliferation? It is same like what you see in carcinoma, adenoma carcinoma sequence. First there is a proliferation, there is a adenoma, there is then the basement membrane invasion, there is a carcinoma. If you go to lymphoproliferation, it's just same. First there is a any immunologic, what I saw, any stimulus like a infectious or immunologic or a genetic like primary immunodeficiency. So there is a polyclonal proliferation of the cells. So after the polyclonal proliferation, so one of the clone may evolve and may give rise to malignant lymphoma. So polyclonal proliferation, atypical lymphoproliferation followed by lymphoma. Clear? So this atypical proliferation can happen to any component. So we have basically three components: B, T, and NK, and third is the histiocyte. So it may affect to anything, either to B cells, whether to T cells, whether to NK cells, or whether to histiocyte. So after this polyclonal proliferation starts, goes on dividing and dividing because of the antigen exposure, because your all total pathways are not activated. So among this polyclonal proliferation, one clone, there is one very nice by pathologist, I forgot the name. It told if you want to, you don't have any risk of cancer, so you should not burn. If a human is born, you have a risk of cancer. If the cell is dividing, there is high chance there is some mutation, some alteration will happen to your genetic things. So nobody is immune to any carcinoma. So there are fewer more prevalent, fewer less prevalent. If the cell is dividing, there is a high chance that something will be done there. So similarly, if there is an abnormal immunoproliferation or abnormal stimulation, your B, T, NKs and your histiocytes goes on proliferation, then something will happen to their genetic damage, and ultimately they forms a lymphoma. So it may be loss of tumor suppressor gene, maybe activation may vary. So how to approach when you see a typical lymphoproliferation? You are not sure it's not a lymphoma, but something else to the lymph node. So what I prefer to do, first you see there is a lymphoproliferation. Do a histological examination. Lymphoma, reactive lymph. First thing is the reactive lymphohyperplasia or lymphoma. I'll discuss one by one. Okay, there's some worrisome feature, right? So do a IHC and molecular analysis, then do B, T, and NK. Still you are not clear. Okay, it's not going to B lymphoma, not going to T lymphoma, not NK, not histiocytic disorders. So inconsistent, atypical finding. Then you need a very good clinical history. Without clinical history, you cannot do. So do a clinical, maybe there's some other node, maybe it's an evolving process, maybe some other node have some other features. You have to take a call whether to, if it is very aggressive, you can do another biopsy. If biopsy is not adequate or inconclusive, find, just keep it as a atypical lymphoproliferative lesion. So for atypical lymphoproliferative, what are the worrisome features you will see in a lymph node? First, the architecture. Architecture is effaced almost all lymphomas. Preserved, except there are few where there is a sinusoidal proliferation. There are only few, like ALCL may be apparent in the sinusoid. Maybe gamma delta T cell lymphoma is going in the sinusoids. Otherwise, most by and large, it is effaced architecture. Whether in a ALP, either is a preserved or partial distorted. Mass lesion is rarely forms mass lesion. Lymphomas for mass lesion. Neoplastic nodules, yes, there is a neoplastic. Reactive follicles, lymphoma in the periphery. Sometimes you may find a reactive follicle like a paracortical type of Hodgkin lymphomas. You may find some reactive follicles. Or mostly you may not expect a reactive follicles, even if you are finding very few in the periphery. Cytological ATP are not expecting in ALP. It is present in the very prominent in case of lymphomas. Angioinvasion, angiocentric. It is not expecting in ALP. It is definitely in the lymphoma. Aberrant IHS. I will discuss one by one what is aberrant IHS. Then the light chain restriction in case of B cells, like your kappa or lambda. It should be admixture. There is a ratio of kappa lambda. It should not be whether one type or kappa or lambda. In case of T cells, yes, TCR gene rearrangement. Okay, TCR gene rearrangement, clonality is always, not always lymphoma, but mostly in skin lymphomas, there is a little bit of doubt, but most nodal structures with a clonal node, very unlikely, it is mostly a lymphoma. If as a general lymphadenopathy, you are doubting a lymphoma, you find a clonal T cells, 95 or 99% you are a lymphoma, but many skin conditions can give it clonal T. So in a T cell, whether a double positive, it's a double negative. Like any double positive, any double negative, these are abnormal. Very rarely you find a double positive cells or double negative cells. Loss of anti-cell marker, like CD5-7 mostly. If there is a loss of anti-cell marker, it is bad. CD4 to 8 ratio S sometimes may be helpful, but I find it is a difficult sometimes to CD4 to 8 ratio unless until it is very obvious. So how to approach a lymph node to call it a atypical lymphoproliferation. There are 5 parts of a lymph node. One is capsule, second is your subcapsular sinus, cortex, medulla, and paracortical layer. So you have a very systematic approach to a lymph node. So in presentation, I will go to our case only. So this is the cortex. This is the capsule. You can see this is a capsule. This is the cortex. This is the paracortical layer. You are not expect to see a complete like surrounding cortex inside medulla because it's all depends on 3D structure. So how you got the lymph, how you got a lymph node, it's all depend. If you go through exactly the hilum, you can see all structures. Otherwise, it will look like this. It's a cortex. There is a medulla, right? This is the paracortical area. In between the paracortical areas, clear? So there is a so what's to see? What are the abnormal lymph node? So there are 10 points. First is the loss of architecture. You are not able to see like this cortex and medulla. See here, you can see this is your what called the back-to-back follicle. There is no architecture at all. Follicle are densely packed. Number of follicles, there is nowhere such written number of follicles. Some people say more than 40, more than 60. Yes, you can find a very back-to-back follicles. Densely packed monomorphic follicle. Uniform size and shape. That's most important. In case of a reactive follicle, see this one. This is a very large follicle. There is a small follicle because as the antigen goes on exposing, you can find a various size of follicle. You will find back-to-back uniform size of follicle. Then pericapsular spread. See this one. So there is this figure. There is a pericapsular spread. So outside the capsule, we are not expecting outside the capsule. Absence of mantle zone. See this the third figure. There is no mantle zone. You can able to appreciate some dark separate lymphocytes around the follicular center. If there is the absence of then loss of polarization. Polarization we find in a follicle like here. See here, there is a dark zone, there is a light zone. Light zone towards the capsule, there is a dark zone. So this is the pattern you are expecting in a normal secondary follicle. Absence of tingible macrophages. Follicular center cell in the paracortical area. For this, you have to do IHC. Like I'll show you the IHCs. This is the CD20. Like you see, this is the CD20 normal follicles. This is the CD3 in the paracortical zone. So you are expecting 20 in the follicle, 3 in the paracortical zone, and few inside the follicle. There is a follicular T helper cell. BCL2. BCL2 is not positive in the follicular center. So you should know what is the normal pattern. BCL2 normally expressed in the CD3. So if there is a more CD3, you find a CD3. But follicular center should be absent. If it is present inside the follicular center, this means it's a lymphoma. Must impression follicular center BCL2 negative, but normal control is 3. If it is completely absent, then means you are wrong. Your IHC didn't work. You have to. It should come in the CD3 population, not in the follicular center. Then the CD10. So you can see CD10 is positive in the follicular center, but if there are many CD10s in the parafollicular area, so that's what called follicular center cells in the paracortical zone. It's not the normal. It's happened in case of a lymphoma. Then BCL6 again present in the follicular center. Then another example of a lymph node. So this is basically a atypical lymphoproliferation or a follicular lymphoma. So this another example, you can see there's a very thin capsule, again back-to-back follicle. We are not able to appreciate cortex and medulla. See, there are very monomorphic follicles, vague follicles. Okay. So if you want to appreciate follicle, don't go for the newcomers. Don't go to higher power. It is the scanner view. You have to see the 4. If you have a 2x, very good. 1.6x, very good. 4x, otherwise everybody has a 4x. You just examine the pattern. Whether the cortex, medulla, light zone, dark zone, capsule thickened, pericapsular spread. These factors. See here, CD20, all of the follicles are CD20. You can see here, they're all monomorphic. There's no much variation in size. But CD3 present in only the paracortical zone. See the BCL2. See BCL2 normally present. So I told you in the previous slide, BCL2 should be absent in case of a reactive hyperplasia, but BCL2 present in case of a follicular lymphoma. So here there's a dilemma. You are seeing here that some paracortical, there is no all factors are there. Like there is no loss of architecture. There's back-to-back follicles. There's monomorphic follicles. but BCL2 is absent. So many people call it a reactive, but no, it's not a reactive. You must understand there is in this WHO there is a stress upon this BCL2 negative follicular lymphoma. These are rare. Must understand that clinically, if it is a lymphoma, generalized lymphadenopathy, old male, B symptoms, it's a lymphoma, but your BCL2 is negative. You cannot call it a reactive. Yes, this is a lymphoma. Rest other factors are present. So what are the BCL2 negative follicular lymphoma? It can present with a follicular conventional morphology. I think I have made few mistakes earlier days in 2014 and 15. In our tumor board, the clinician used to stress, no, it can't be a reactive hyperplasia. It is definitely a follicular lymphoma or some lymphoma. But how can you say it is a reactive follicular hyperplasia? But our argument is BCL2 negative. How can you call? I think we have missed one or two cases earlier, but currently, if you see, these are the BCL2 negative follicular lymphomas. So how can present, how they look like BCL2 negative follicular lymphoma? It may be with conventional morphology like the previous one, may be a diffuse variant, usually localized inguinal region, and another was a primary cutaneous follicular lymphoma. That's also a what called BCL2 negative. So there are two other mutations apart from this BCL2 1114 translocation. They have a deletion of 1p3, 1p3.6, or it could be a TNFS sporostata 6 mutations. So you have to identify those cases which are clinically looks like a lymphoma but BCL2 negative. So my first part is over, like to identify whether it is a lymphoma or not lymphoma, or reactive hyperplasia or a follicular any other lymphoma. So if it is a reactive, it's okay, fine. So next is what are the other infectious causes? I told you it could be viral, could be bacterial, could be parasitic. So most common is the viral one. You can ask me questions in between also. There is no issues because it's very monotonous to give lecture. If you have any doubt in any slide, you can chat us. Dr. Kaur will ask me in between. You can interrupt me, no issues. It should be a bilateral conversation. That will be good. So next is the Epstein-Barr virus, viral induced. Hello, am I audible to all?
Yes, sir. Go ahead. You are audible.
Okay. Dr. Kaur, if somebody want to ask, they can ask me and they can stop me in between because lymphomas are a little bit tricky, so they can stop me. If they can write in the chat box, you can stop me and ask the question. Okay. That will be a good bilateral interaction.
Okay.
So for infectious, for viral Epstein-Barr virus, then your HHV8, then is your HIV. These are three common viruses you will encounter in a day-to-day life. So what are the other conditions like toxoplasma and April? So let's case one example. So this case referred to us as a 6-year male. I am just masking this because initially we have a history of tonsillitis. This is outside AIIMS, which has the patient has a large tonsil. They excise it and they call it a Hodgkin lymphoma. Then the patient come to our center for further treatment. So when we review the slides, so we have this much of a history like tonsillitis, cervical lymphadenopathy, tonsillectomy, Hodgkin lymphoma. Clear? So when we review the slide, see it is a tonsil, right? So there is extensive necrosis of the surface epithelium. You can see here there are very reactive follicles. I'm sorry, this is a very bad section, but it is beyond our control. This is a very poor fixation from outside.
Sorry, sir. Sorry to interrupt you.
Yes.
Dr. Soumya, sorry to interrupt you. There is one question in the chat box from Meera Radhakrishnan.
Yes.
Sir, could you please explain once more on BCL2, BCL6, CD20 in case of follicular lymphoma?
Sure. I'll go back. See, the follicular lymphoma, these are the normal, you have to decide based upon your morphological features, then comes the normal part, how they look like. So this for this case, this is not the normal one. This is the this case is this one, follicular lymphoma. You can see this is a CD20, diffusely positive in the paracortical zone also in the follicles. Then this is the CD3. You can see there are few CD3 in the paracortical zones. Here in the BCL2, BCL2 is very diffusely positive. So how to interpret BCL2? BCL2 normally comes positive in the CD3 only. So if you are seeing a CD3, BCL2 in the CD3, then yes, your internal control is there, but it should absent in the follicles. If comes in the follicular center, so this means this is a abnormal BCL2. So it's happened in follicular lymphoma. Any follicular center cell should not be BCL2 positive. So what can be BCL2? All normal BCL2 positivity, all CD3, all T cells, mantle zone, marginal zone, normal mantle zone, marginal zones. These are normally positive in a what called in all almost all low-grade lymphomas which arises or indolent lymphomas arises from this is done BCL2 positive. But normal reactive follicular center, germinal center, they are negative for BCL2. But here you are seeing all are positive for BCL2. Clear? Then the CD10. Normally CD10 should be positive only in the germinal center. There are 4 germinal center marker. How to prove these cells are germinal center origin? That conventionally people use 2 markers like CD10 or BCL6. When there is any, if time permits me, or today I'll show you the normal pattern or how to interpret the normal IHC, because otherwise I'll not complete this one. So CD10, BCL6, the conventionally used. There are 2 newer markers we are using like GSET and LMO2. These 4 are germinal center markers. So any lymphoma which arises from the germinal center, even if the normal germinal center, these 4 markers should positive. So you are not expecting CD10 positivity in the interfollicular areas. Clear? So here CD10 and BCL6, and here you can see the markers are positive in the interfollicular areas also. Clear? Am I clear to audience? So normally you are not expecting a CD10 and BCL6 to positive in the interfollicular area. Like if it is going present in the interfollicular area, this means there are the germinal center cells which are what called going to migrating or going to the interfollicular zone. So that is the evidence there's a lymphoma. If you are a pericapsular spread, those cells, if comes to 10 BCL6, then it's a this lymphomatous cells which are migrating or invading the capsule going to the post-capsular regions. Clear? BCL2 positivity in the follicular center, then you have to prove those are follicular center cells. Then you do CD10, BCL6. Because what's the problem? Sometimes you find a primary follicle, very rarely, or a mantle zone which is abnormally cut. So you can find, we are thinking, okay, this is a nodule which is positive for BCL2, this is a lymphoma. No. Just mere presence of BCL2 is not a lymphoma. You have to prove those are germinal center origin. So you have to do markers like CD10 or BCL6. Yes, this is BCL2 positive. Again, this is BCL6 and CD10 positive. This means this is a germinal center or which is BCL2 positive. So that's a abnormal. That's a follicular lymphoma. Am I clear? I think
yes, sir. Yes, sir.
Okay.
Thank you.
Okay. So,
yes,
but this is the only exception is the when BCL2 is negative. So when what to call this is a reactive or a lymphoma? Yes, this is a lymphoma. But how if all other criteria, there is one entity called BCL2 negative follicular lymphomas. You must remember this is you must clinically fit. Okay, this is patient is a lymphoma, no doubt, but BCL2 is negative. So this might be in this category. So what happened in follicular lymphoma 11-14 translocation? Everybody knows BCL2 and IGH gene, immunoglobulin heavy chain. But here there are deletion of 1P at the 3.6 position or mutation of TNF-SFR or STATA6. So these are these entities people now recognizing as the okay, BCL2 can be negative in a follicular lymphoma, but these are rare. First, you have to you can do this mutation or deletion, but this but before this you first all your morphological criteria and clinical criteria fit into a lymphoma. Clear? Next, come to infectious. For infectious, Epstein-Barr virus, 3 viruses you will encounter like Epstein-Barr, herpes, and HIV. But among the most ubiquitous is Epstein. Second is the HIV, HHV8, very rare. We are also not encountered too much. Like tonsillitis, cervical lymphadenopathy. But remember, this is only 6-year male. Here history is written 3 months. Okay, so why I am stressing upon history, I will go back. See a 3-month history of a cervical lymphadenopathy, tonsillitis, Hodgkin lymphoma. If you see the what called this slide, you see here This is the surface of the tonsil, arthropoietic squamous epithelium. These are all necrose. Even if the crypts are necrose, but you are finding many reactive follicle in between, just deeper down. You can see there are many reactive follicles. So when we go higher power, so these are the reactive necrotic zone, go high power. You can see there's a polymorphous population, such a bizarre cells. It look like a nodular sclerosis, very bizarre RS cells. See, these are large cells. There are many large cells here. And in the background, there are many small cells. So classical teaching, you can find a occasional RS-like cell or a RS cell. So for RS cell, whether it is a Hodgkin cell, mononuclear, or Reed-Sternberg classical cells, maybe popcorn variant, maybe mononuclear variant. Okay, you can find any one. Popcorns basically you find in nodular sclerosis. So basically this background, if you forget about anything, so like the background, whether tonsil or anywhere. So polymorphous population, histiocytes, small lymphocytes, along with these large cells. So more high power, see, these are very apoptotic kind of cells. You can find a mummified cells, you can say. These are mummified cells in the background. So certainly anybody can think of a Hodgkin, what reported outside. See here, but what's the odd point here is tonsil Hodgkin lymphoma, Wilder ring Hodgkin lymphoma, very rare. Skin Hodgkin lymphoma, never happened. Skin and Wilder ring, if you are saying a Hodgkin, there must be people say like it is a node, any retropharyngeal node, any lymph node which has a Hodgkin which is extending to this. Similarly, skin Hodgkin must be some node is there in beneath like a inguinal. If it is a skin ulcer, maybe Hodgkin is there which is come. So please, before coming calling any skin or mucocutaneous region Hodgkin lymphomas, sorry. Okay, so in a skin and mucocutaneous region, if you are calling a Hodgkin lymphoma, you may be chances wrong. So you must know there is a term called mucocutaneous ulcer, which mucocutaneous ulcer, which introduced in this 2016 or 2017 WHO, which is very important entity because this mucosal region usually never have a Hodgkin lymphomas. So CD20 is very strongly CD20. Backgrounds are CD3. Maybe others are polymorphs or histiocytes. So the CD30, these large cells, see here, CD30 positive, CD30 positive, CD30 positive, CD15. I am not convinced with CD15. There are few CD15. Must remember CD15 normal positivity, CD30 normal positivity. CD30 is positive in all immunoblasts, sometimes in the plasma cells also. So CD30 can come in immunoblasts, CD30 can come plasma cells, and also these abnormal RS cells. Next is your CD15. CD15 comes positive in all eosinophils. Those are internal control. So CD15 positive in all myeloid cells, in fact. So in a Hodgkin lymphoma, so these are the eosinophils. Then the histiocytes. Histiocytes can take very strong CD15 positivity and they'll get confused. So probably this positivity for me, these are not. This cell, the large cells are negative. There are few cells which are CD15 positivity. So when we are interpreting 30 and positivity, you see the background. You must have a good background like the nuclear stain or the counter stain to say, oh, yes, it is a Hodgkin lymphoma, it is a RS cell or a mononuclear cell which is showing as 15 and 30 positivity. See the EBB LMP. EBB LMP positive. Now 15 positive, 30 positive, EBB LMP. Hodgkin. But one peculiar thing you can see, there are many small cells which are EBV positive, which is very abnormal. See here, see these small cells. The large cells definitely positive. Why the small cell will come positive? The small T cells, the background cells never comes positive in case of a Hodgkin lymphoma. These are only the large, this is the latency pattern. So this is probably acute viral infection which is causing this positivity. So there's the doubt. Then we did the CD4/8. So usually in Hodgkin lymphoma we find a CD4 positive, more background are CD4. See here is a CD8. So this is a cytotoxic type of background. So there are many odds here. Like first start with a mucocutaneous region. Second is the EBV positivity in the small cells. Then the absence of CD15. So this goes suspicious. So till now, what is the story we have? We have a story of a fever for 3 months, tonsillitis, tonsillectomy, cervical lymphadenopathy, ulceration of the epithelium, polymorphous cell, RS-like cell, 20 positive, 30 positive, 15 positive, LMP positive, EBV, 15 negative, 3 negative, 8 is more than provisional diagnosis Hodgkin lymphoma. Then we ask the clinicians, oh no, it's not possible. We just, when such a dilemma, we just file the case. Our standard practice is we file the case for want of clinical details, and we have also a tumor board where we can discuss these cases. So in the tumor board we discussed, in the next we have every Tuesday we have a tumor board. So they told it's the JR which mistakenly write the 3 month. It's not the 3 month. It is just 6 days only. The cervical swelling is only 6 days, but unfortunately there is some miscommunication. You know, these OPDs, it's not the mistake basically. It is basically due to busy schedule. All patients are there. They're just mistakenly found. It is only 6 days. Fever, tonsillitis for 6 days. Fever for 6 days, they immediately do the tonsillectomy. I don't know why the clinician do, but maybe some indication. That's not my job. Then the LDH is within normal range. It's up to 300 is normal. 2 to 400 is normal. Our range is the very lab to lab. Okay, so it's only 3 months. So that's why I say if somebody says 3 months, then I can think of a lymphoma. Or 6 months, I can think of a lymphoma. If say somebody I have only a node of 6 days, then somebody excise it and call me a lymphoma, I will not trust. No, it's not possible for a 6 days. It may be previously there, you have not noticed if it is a lymphoma or that it is a atypical lymphoproliferation of any causes. So what is this is basically, then we did the monospot test which comes positive. This is basically nothing but an infectious mononucleosis. The patient has a triad like tonsillitis and pharyngitis, cervical lymphadenopathy and fever, right? So why it confuses with non-Hodgkin lymphomas, also Hodgkin. Non-Hodgkin when there is a deep florid immunoblastic proliferation, Hodgkin presence of atypical cells. So must remember there are few things. What's here? Like there is a polymer, like fine. First, the mucocutaneous region, it's not a Hodgkin. Second is there is a distortion, but not obliteration of the normal tissue architecture. You are seeing now many follicles, reactive follicles, just towards the downstream, but in the surface, when there is a ulceration, you are finding everything inside the ulcer. Okay. So next is the reactive follicle is present, follicular hyperplasia is present as the capsule, medullary sinuses, cortex. So this is very, if these things are present, you think of it. And then presence of EBV, you can do EBER also. EBER is more sensitive. EBV, LMP may not work, so you do EBER. So this will show you in the small cells. Clear? So how can an infectious mononucleosis can present? This is a nice paper in modern pathology by Zuckerberg. You can see paracortical expansion, architectural distortion, polymorphous infiltrate, increased immunoblast, Rich-Sternberg, everything is there. These three of three, right? In the Waldering, 15 of 15, like paracortical, architecture, polymorphous, increased immunoblast. So these can present. So you take a proper history, examine the slide properly, and do a panel of immunohistochemistry to make it around. Clear? So in one thing in eosinophils, rare in infectious mononucleosis, usually numerous in classical Hodgkin lymphoma. In our case, it is present. The two other markers which will be helpful is LCA, OCT2 and BOB1. LCA is very helpful. It's never comes in your what called RS cells, but it is very difficult to interpret. Very difficult because all the background cell will be LCA positive. You're not able to know whether your cells of interest will be positive or not. Sometimes may helpful if your isolated RS cells are present, then only do, otherwise it is very difficult. OCT2, BOB1, see, Hodgkin and these cells are B cell origin. Hodgkin is a B cell lymphoma only, but the cryptic B antigen. So what you can do, you can do other markers like PAX5, 79A. So it is usually so loss of CD20 and presence of PAX5, some B markers. But in case of atypical lymphoproliferation, you find all markers. 20 will be strong, 79 will be strong, PAX5 will be strong. All B markers are present. Then OCT2, BOB1, usually loss of a BOB1, maybe OCT2 present, but BOB1 will be lost. In case of normal conditions, OCT2 will be, both will be present. OCT2 and BOB1, both will be present. Clear? So next comes another case. This is a very recent case. I think in a month this case comes. This is a 9-year male. The post-kidney transplant, some due to nephrotic syndrome, now present with a generalized lymphadenopathy and some worrisome is a brain lesion because basically there's a spelling mistake is there. Sorry, because I'm entering the this morning only. So so there is a presented because of epilepsy only, because there's a epileptic attack, so they come to center, they do all the investigation. There is a brain lesion also. There is also multiple generalized lymph node, multiple lymph nodes. So the initially they try to took an true cut biopsy from a lymph node, but it comes only fat only and with few cells. So we advise them to do a lymph node. So this is the excised lymph node. You can see in the this is the 1.6x magnification. You can see. So almost there is vague follicles. Higher power. There are 3 lymph nodes. 1, 2, 3. See, these 2 are looking normal. Like there is some paracortical expansions, but their follicles are still present. Very thin capsules. But when you go to high power, see these cells. So these are the very large cells in the background of these small cells. So there are many large cells which are looking apoptotic looking. These are CD3 positive background cells. This followed by this 20 in the periphery. So this zone is expanded. Basically, paracortical expansion is there, but follicles are present throughout. All the follicles in the periphery. There's only expansion of this paracortical zone. This is the PAX5. PAX5 is a nuclear stain. This is a B cell marker which will helpful most of the time. So you can see the PAX5 positive nodules. If you go to high power, these large cells which are seen here, these are all strong PAX5 positive. So PAX5 to interpret in the case of Hodgkin lymphoma, it is a very deemed to weak positivity. How to compare with these normal B cells markers? Then we do the CD30. This CD30 positive, but see the characteristic distribution of CD30. It is not in the paracortical zone, not in the T zone. It is just around the follicle. See here, these are the B follicles in the periphery. See that multiple pictures of CD30, same parafollicular zone, some inside the follicles. See, this is very characteristic. So this is somehow you have to clue you are not dealing with a Hodgkin lymphoma, because here I thought it could be a Hodgkin lymphoma. Because the patient is post-transplant, there's generalized, there is a brain lesion. Brain in Hodgkin, again a rare one, but still patient has a general lymphadenopathy. But it's immunosuppressed. But when you see the CD30, it's all coming around the follicle. So usually the immunoblast, when they come out of the germinal center, they usually first arrange around this follicular, these secondary follicles. Then they go inside this paracortical zones. So if you are seeing CD30 positivity very strong around this germinal center, so don't think of a lymphoma first. It could be a reactive immunoblast also. See, we did EBV LMP. So this is not a great picture, but you can still appreciate only those regions. There's multiple same pictures inside here. Here, see this capsule. See this one. These are all present in the same immunoblast which are positive for CD30. And there is a higher power, which is the cytoplasmic positivity EBV LMP. There's CD4 and CD8. Again, the CD8 is more. So same thing. This is nothing but a post-transplant case. So you are finding a EBV infection which is reactivated, which is causing a recent infection, because 9-year only, maybe a recent infection. This is the EBV-induced lymphadenopathy, benign, nothing to do. So we just follow for last 1 month. Patient has they just suppress the immunosuppression. They just reduce the dose of immunosuppression. The patient is fine. The lymph nodes are automatically start decreasing. The patient doesn't know without epileptic, without anti-epileptic drugs. Patient doesn't know for the symptoms. So if you treat it Hodgkin as a Hodgkin lymphoma misdiagnosed, the patient could have died of chemotherapy toxicity. So very important to diagnose this EBV-induced lymphoproliferation, because in our country the general overall patients are malnourished. Many patients comes from the rural area where the hygienic may not be maintained properly. So you find this EBV infections which can confuse us. This is another same case. Like another case, like this is a 60-year male with cervical lymphadenopathy for 3 months, diagnosed outside, referred to AIIMS as a Hodgkin lymphoma. You can see this architecture. You can see these are follicles with some increased vascularity. Do the CD320. This is normal. Only I don't find any abnormal location. CD23 again normal. CD15 negative. There are few EBV positive cells. Again, nothing but a EBV positive lymphoproliferation. We advise these cases to follow up after 3 months. The patient has nothing. There is no progression at all. In fact, the size reduces automatically. So this is their EBV-induced reactive lymphadenitis. So So whether normal EBV is present or not in a normal patient, if anybody of this participant will go and do a lymph node biopsy and do a EBV, yes, if you do EBV, you find normal 0 to 1, because this is what called as that if you see the epidemiology, there is one paper from a South India serological survey which shows 85 to 90% population of our population is infected by very early age. By age of 10 years, you will be infected by EBV. Maybe acute, you may not able to notice it, it will subside and the virus will be there in the latent phase. When it will be activated, nobody knows. But in immunosuppression, definitely it will getting activated. Clear? So 5 to 10-fold more EBV positive cell in reactive lymph in patients with HIV or any immunosuppression. Okay, also elderly, you can expect a 1 to 5. So you should know how to interpret these cells. So what are the RS cell mimickers? Like how to differentiate is the immunoblast, like or any atypical lymphoproliferation activated lymphocyte CD30 positive cells. These are binucleate or multilobated cells with abundant cytoplasm, large eosinophilic nuclei. You are not expecting in a immunoblast. Immunoblast usually you are not expecting a very large nuclei. Eosinophilic large nuclei extending at least 1/3 of the nucleus. So it is very rare in case of a what called mimickers. But in classical Hodgkin, you find a very large nucleolus. Clear? So come to the next case, like a 50-year male, known case. So we have covered the EBV induced the spectrum. It could be infectious mononucleosis or simply a EBV positive lymphadenopathy. Next is your next case is a 50-year male, known case of HIV, cervical lymphadenopathy. So what can you see here? There is a thin capsule. There is no extra capsular spread, but you are finding with a little bit of increased vascularity. So it is the marker. See the Ki67. You can. This is a nuclear one. This is a large follicle. I will explain how to interpret Ki67. Okay. So you will go to this follicle. See, this is a coalescent of follicles. One follicle merging to other. Okay. This is a large follicle with increased vascularity. You can see the perifollicular region. Many vascular channels are there. Large cells, increased follicularity. They see this is a large follicle again. So we did the CD20. As usual, it's positive in the follicular center only. Like CD3 in the paracortical zone. So I'm not getting any abnormality except this coalescent follicle. So CD23 is a very good marker for to know whether there is a diffuse involvement or a focal involvement. So like if you do a follicular lymphoma, you have to do CD3 23 because it's in our panel. We have a panel of indolent lymphoma, we have a panel for high-grade lymphoma, for Hodgkin lymphoma. For indolent lymphoma, we have panel like CD3, 25, 23, cyclin D1, CD10, BCL6. These are a panel. So 23, how 23 will helpful because you have to know, as per WHO, you have to report like percentage of follicular area, percentage of diffuse area. If in a if it is a diffuse area, you find a DLBCL like region, then you have to report like DLBCL in background of follicular lymphoma. So CD23 help in this way. So if you see CD23, it's showing some coalescence of the follicle. But except apart from this coalescence, the follicle are there. The see there is a variable size follicle. There is a small, there is a very large, there is a medium size. Okay, CD20 also few immunoblast in the parafollicular regions. CD30 positive. So I am repeatedly showing the CD30 because don't expect the CD30 and CD15 positivity equivalent to Hodgkin lymphoma. Not at all. RS-like cell can be seen in many cases. If you read the Jaffe's paper in 2014, I think, then followed by many papers have come. Like even RS-like cell can be seen in many in T-cell lymphoma. So classical teaching is T background with few RS cells which is 1530 positive is a Hodgkin lymphoma. No, it could be a T cell lymphoma. You have to see the background because the background should be mature one. So that's what I'm saying. Just mere presence of CD30 is not a Hodgkin lymphoma. Even if CD30, 15 EBV, all three present not a Hodgkin. You have to give a holistic view, clinical pictures, the pathological pictures. Then we will interpret the lymphomas. Not only IHC, not only the clinics. Okay. So here many CD30 positive cells. See, these are reactive follicles just around the follicle. Yes.
Dr. Soumya, Please, sorry to interrupt you. There is one question from Dr. Arshi Rajesh.
Yes.
He said that EBER and IMP, when to do it and how to interpret it, and when to do CD4, CD8 in suspected Hodgkin lymphomas.
See, EBP, LMP, it's not, it's EBP, LMP, when to do. Because EBP, LMP, if you can do, I'll suggest the EBER. EBER is very good, very high sensitivity. But if you, because it is in situ hybridization, it is costly. So the alternative, it's not alternative, but yes, you can do LMP. It's usually in our all panels, like it is a Hodgkin panels. If you are seeing atypical lymphoproliferation, if you are seeing RS-like cell or mononuclear cells, Hodgkin cells, then you should include in a panel. Like our Hodgkin panel is CD3, 20, 15, 30 EBB-LMP, right? So then CD4 and 8, we usually don't do in a routine case of Hodgkin lymphoma. But when we require a CD4 and 8 to do as a part of a Hodgkin lymphoma, if you see, as I told you, the background population is not good. Like the background population of a Hodgkin lymphoma is a mature lymphocyte. Mature, if you are finding the lymphocyte have indentation, they have very large vesicular nuclei, but you have a Hodgkin-like cells, then you do CD4 and 8 to look for what? Because Hodgkins usually have a CD4 kind of cell. If you are suspecting it is a virally induced lymphadenitis, in viral induced lymphadenitis, you find more CD8 than CD4. So in that case, you use CD4 and 8. It's not in the routine panel. If you have a doubt, you are not sure to give a Hodgkin lymphoma as a diagnosis on morphology point of view or clinic history is not matching. Like if somebody tell like a 15 days history and Hodgkin lymphoma, I will not trust. Either the patient doesn't know it is a subtle features. It could be what called acute infectious mononucleosis. Okay, so in that condition, you do CD48. LMP we usually include in all cases as a panel, but it's optional. It's not mandatory to do all Hodgkin, but if it comes positive, it will be helpful for you to interpret. And if you I heard about Dr. Nareskik's lecture in few days back. He told he included as EBB all DLBCL. It's not EBB, it's the EBER. Okay.
Thank you, sir.
So next is the CD30. See here, classically the CD30 is presenting just on the perifollicular lesions. 15 is negative. These 15s are positive in the histiocyte. Remember, these are not the large cells, these are histiocytes. So again, EBB LMP is negative. See the Ki67. How to interpret Ki67 in a follicular lymphoma reactive node? This is a very good marker, but very difficult to interpret. Reactive follicular hyperplasia has a more Ki67 or more Ki than the what called the follicular lymphoma. Follicular lymphoma grade 3B when happens, there is only you find a higher Ki. Otherwise, reactive has more than the follicular lymphoma grade 1, 2. Follicular lymphoma has very few low Ki. Reactive has a more high Ki. See here how strong the Ki67. Second, Ki67 has a polarity. Polarity in the sense you find a very large positivity in one zone, like dark zone and red zone. You find very dense cluster of Ki in one zone, one pole, and another pole very few. See here, dense, less. So you have to interpret in a proper way Ki67, that will be helpful. Clear? So what is the how to this is basically nothing but a HIV induced lymphadenopathy. So what is HIV induced? It could be grade 1, grade 2, grade 3. It is the florid follicular hyperplasia, exuberant hyperplastic features, then focal expansion of the interfollicular zone with the monocytoid B cells or transformed B lymphocyte, then the reduction of the mantle marginal followed by the follicular lysis. In the grade 2, there is increase in relative reduction of the mature lymphocyte, increased number of plasma cell or proliferation of the perifollicular vessels, then the reduced or regressed germinal center which becomes sclerotic. Grade 1, grade 2, grade 3, it starts with florid follicular hyperplasia, then the mixed pattern, then the follicular lysis, followed by the lymphodepletion. So this is the HIV-induced lymphadenopathy. So the HIV can cause many cases. We have our data which can show it can go mostly what called plasmablastic lymphoma, followed by the DLBCL. Okay. So last one in the viral section is the HHV. human herpes virus lymphadenopathy, we don't have any cases. I have taken this table from WHO 2017. Here there is one entity added like HSV positive germotopic lymphoproliferative disorder. It is very difficult to diagnose. So what they are saying, you can find this one like you have a reactive follicles with full of immunoblasts. The follicles full of immunoblasts. If you do HHV LANA, they come strongly positive. We don't have any cases. These are all slides from WHO 2017. I've taken just for educational purpose. The disease present with localized, sometimes multifocal lymph node, medium-sized to large lymphoid resembling plasmablast. And these plasmablasts are negative for 20, 79A, 138, CD10, negative for CD30, but positive for HHV8 LANA. If you have a HIV positive cases, LANA, they are also positive for EBV, both. They can positive both EBV and HHV. Clear? So now this all over the viral component. Okay, acute bacterial lymphadenopathy very rarely will do a what called biopsy for acute bacterial lymphadenopathy. Very rare. We have not seen a single case of acute suppurative bacterial lymphadenopathy mimicking lymphomas. I am discussing only the like TB can also mimics, but I am not discussing because there's only 45 minutes lecture. So case 4, then we come to other part, the histiocytic disorders which can mimic. This is a 9-year girl with present a large neck mass, CBC normal, PS normal, and this patient before coming to us already completed 6-month course of ATT because outside diagnosed as a tuberculosis, not responded rather than increase in size. You can see the confluent nodes. So when we did the biopsy, we did FNAC first, then suggested biopsy. I'll show you all pics. So see the biopsy, there is a little bit of thickening. Anyway, some vague nodularity, but anyway, not only nodularity, this low power also seeing this interfollicular zone having large cells. You can see if you go to high power, there are few sinusoids filled with histiocytes. This sinusoid, there are few remnant follicles. The rest are abnormal cells. Go to high power, very atypical cells, embryo-like cells, pleomorphism. See the kind of pleomorphism it's showing. See, there is a mitosis also, atypical mitosis. Atypical mitosis, pleomorphism, embryo-like cells, and there are areas which are the sinusoids showing classic histiocyte, sinus histiocytosis also. Then further high power, you can see in the FNA part, too much giant cells. You can see this pleomorphism, these cells are showing. So it's looking some horizon, so I advise this biopsy. You can see here, there are too much pleomorphism, looks like a malignant lymph or any lymphoma malignant lesion only. So you go to higher power, there are some emperipolysis. See here, there are few of the histiocytes showing very benign looking histiocytes have emperipolysis, but rest surrounded by this atypical looking, very atypical lymphocyte. So we did CD320, there are only few, the architecture is completely obliterated, 23, occasional follicle completely obliterated, CD4. There are many CD4s in the background, those are basically those CD3. Then we did CD163. CD63 is a good marker, but not very specific to histiocyte. It can come in myeloid cells also, some other cells, but 63 is better. If you are using 68, then you should know which clone you are using, whether KP1 or PGM. PGM is better than the KP1 clone. So next is the 163 is a better marker for histiocytes. You can see all cells are histiocytic origin. Now we are clear there is a histiocytic lesion. See the Ki67 is very high for a histiocytic disorder. Then as there is some nodules, so we did CD15. It's negative in the large cells, only few. Probably these are the eosinophils or polymorphs, or some are histiocytes also. EBV negative, CD30 again in the few cells, S100 again randomly distributed in the follicles. CD1A is completely negative, Langerin is negative. See, CD1A comes, Langerin few cells can also come in your dermatopathic lymphadenopathy. There is a very nice paper in pediatric developmental pathology. You should know how to interpret, because LCH is a good possibility, people say, but you must know LCH is a diagnosed very easy in the skin, not in the lymph node, because very rarely it involves the lymph node, because sinus histiocytosis, they can look very bizarre and they are very strong for CD1A. not Langerhans very strong, but it can also come positive in Langerhans positive. So in a lymph node, before giving LCH, make sure that it's not a dermatopathic lymphadenopathy, it's not a simple sinus histiocytosis which causing CD1A or Langerhans positivity. So nothing is, so that's why I'm saying no marker is absolutely specific in hematolymphoid malignancy unless until you have a proper context, your interpretation should be a proper one. Then we did MPO is negative. Then we did some thoughts could be ALK1 because of monomorphism, abundant cytoplasm, ALK is negative. Then EBB because it's presently outside treated, so we did, but it's not required. So now what's this case? So this is basically case of a histiocytic sarcoma in a background of a Roja-Dorfman disease. Clear, this is a histiocyte, and the patient is refractory for last 9 months. This 9 or more than 1 year, I think. The patient is on follow-up and is treated with some chemotherapy, which is not of a Hodgkin, not of a sarcoma. In between, our clinician tried, but it's failed therapy. Now the patient has a multiple lung nodules, so it is progresses. This histiocyte sarcoma is a very aggressive lesion. It will ultimately never treat. Never respond. Now the patient is a sick condition. Just last follow-up, I think in 2-3 months back, the patient again came to us. So next, what is Roja-Dorfman disease? These are few slides of histiocytic disorder I got from Professor Iyer. These few slides, Professor Venkat Iyer. So this is basically a Roja-Dorfman. Every pathologist knows Juan Roja. He just recently died. We are all reading his book Ackerman. So the and the another person, Dorfman, two pathologists, but they described the same lesion. So usually present in the massive lymph nodes. Roja-Dorfman present as a massive neck swelling. Etiology not known, probably antigen stimulation. So what is the characteristics? Characteristics empirical. Dr. Kaur, how much time left? Hello? Hello?
The time, although time is over, but you can explain your slides, sir. Take few minutes.
Okay, so can you have a 10 minutes so that I'll rapidly complete? 5-10 minutes?
Okay, sir. Okay.
Okay. So this is because there are many entities. I'll at least try to cover the major ones. So what is empiricollosis and what's called your phagocytosis? You don't have a intact. You can see the follic lymphocytes with a surrounding halo. So there are many lymphocytes. So this is called empiricollosis. So in Roja-Dorfman, what is the character? There is this massive patient present with a massive lymph node, and if you find empiricollosis very well demonstrated in the FNAC, but it is very difficult. You will find these large histiocytes with intact lymphocytes, plasma cells, all those. And in case of histopathology, you find the dilated sinuses with the these features. And you can find this is a very classical side of a Roja-Dorfman disease. And this may vary from 60 to 100. This may be florid. This is cases. So we did how these histiocytes are much larger. We published in 2012, like 2013. These histiocytes are much larger. We just morphometric analysis is around 16.7 micron compared to the reactive histiocytes, which are 10 micron with the p-value. How can it? What are the differential diagnoses? It's always a lymphoma. And see the number of nodes. It can be go up to 8 into 7 centimeters. So you have a massive lymph nodes. And the number of lymphocytes, it vary from 4 to 13. So we try to see the correlation, but there is no correlation at all. You'll find like this. Okay. So in a single case, Professor Iyer showed it is increasing, then starts on decreasing in a single case. So what associated finding? You find a elevated ESR, hypergammaglobulinemia, and leukocytosis. Median age is usually 20 years. So I'll skin, and what are these positivity is positive for mostly S100 protein. It is very strongly positive for the S100, but not the CD1A Langerhans. And the next confusion is the dermatopathic lymphadenopathy. These what called histiocytes with indentation. It may confuse us with, but you will always find a pigments. Clear? So next case is 11-year, right side cervical swelling for 6 months, clinical diagnosis lymphoma, possibly Hodgkin. See here. You can find the mature lymphocyte and these large cells with a prominent nucleoli. See, there's also a binucleate one. So this is FNAC. swelling for 6 months, this background. So in FNAC, we usually only suggest for what called biopsy. So this is reported as a Hodgkin lymphoma, suggestive of Hodgkin lymphoma, advise a biopsy. So because this has a very bizarre cells. See, these are binuclear bizarre cells. Binuclear bizarre cells. So aspiration cytology, the report is a lymph node biopsy properly. See the lymph node biopsy. What you can see? This is a classical onion skinning. High power onion skinning surrounded by a vessel traversing to the center. Right angle traversing the vessel. So this is a Castleman disease. So Castleman disease, what's happening in Castleman disease? It is basically abnormal dendritic cell which proliferates. So in a dendritic cell, they can come close together. They can mimic as a Hodgkin lymphoma and cytopathology. Many case reports you will find. So the hypothesis is Hodgkin lymphoma and Castleman disease. They can be together. They can be both the entities can be in the same case. One can be followed by other. One can mimic each other. So very carefully you should examine these cases. Okay. So this is a Castleman disease. The characteristics is the onion skinning. Then the right angle. This is the vessels. You can see the entering at the right angle to the follicles. See these are the dendritic cell which confuses with your RS cells. Yeah. So our so this is by Benjamin Franklin. I will not go to in detail. Basically unicentric, multicentric. There's a recent article in 2017. You must every lymphoma who is practicing. So how to classify, because there's the IL-6 treatment in case of idiopathic variant. So you should read those articles, classification. So it could be unicentric or multicentric, or it could be hyaline vascular or plasma cell derived. There are two things. Most multicentric are usually plasma cell type, unicentric are hyaline vascular, but you may find many mixed cell variant also. So etiology nobody knows. I'll skip this. So if you go to hyaline vascular to plasma cell, hyaline are uni, plasma are multi, and plasma cell multicentric are usually HHV8 and HIV positivity. And it can progress to lymphoma. So recently in Indian Journal of Hematology, we published the largest series from India, around 53 cases. You can see the mostly unicentric, few are multicentric Castleman diseases. And these are the treatment, no standardized treatment till now, but only in 2017 the paper came where they are trying to the treatment. The patient receives different treatments. So next, I think I'll end after this case only. So this is a 40-year female, fever for 15 days, cervical lymphadenopathy, CBC normal, chest normal, autoimmune markers negative. So you can see there's a complete effacement architecture, many histiocytes. See, there is a necrosis. Okay, but interestingly, when you find necrosis, you find polymorph. So this is basically a necrotizing phagocytosis, necrosis, apoptotic debris. You find lots of apoptotic debris. So this is called necrotizing lymphadenitis without eosinophils. So this is basically a Kikuchi's disease. So Kikuchi's, Kimura's, and Castleman's, these are all autoimmune etiology developed diseases, and these are very good mimickers of lymphoma. They can confuse you. When you suspect a Kikuchi disease, how to diagnose? Kikuchi has a different stages, but in all practical point of view, you should rule out first all autoimmune markers. This should be all autoimmune markers negative, and you find no eosinophils here. Then if you do a CD4, very good marker, it should be CD8. Normally CD4 should be there, it should be CD8. And all histiocytes are MPO positivity because there is no eosinophils, but no polymorphs, because necrotizing lymphadenopathy without polymorphs. But you find histiocytes are MPO positive, but difficult to interpret. Okay, so necrotizing, this is how it will look like in case of in your FNAC. It may be doubtful because lots of apoptotic debris, this very scary looking cells. But if you do see, they can have a very varied presentation, very high grade fever, generalized lymphadenopathy, but it very well respond to steroids. So you should diagnose these cases. So these are how they look like. Crescentic, very classically cytology people, cytology they describe the crescentic histiocytes, and these are the tingible body macrophages. Clear? So this is the Kikuchi's disease. One more I will not discuss. One more disease is the Kimura's disease. That they also present with neck swellings, no anorexia. So what you find, the serum Ig is strongly elevated, and you can find this eosinophilia also. So you can see eosinophils. You can find this called polykaryotic bodies. It may confuse us with viral inclusions. If you see the nodes, there is a marked increase in the eosinophils. And what is the characteristics in these eosinophils? Formed by eosinophilic abscesses, and the eosinophils goes inside the germinal center. See here, these eosinophils entering to the germinal center, destroying. So similarly, if there is a plasma cells entering to the germinal center, there are many entities on plasma cells which can mimic lymphomas or can confuse you. Similarly, if plasma cells enter to the germinal center, there are 2, 3, like SLE, IgG4, or syphilis. If there is a eosinophils, you should rule out Hodgkin lymphoma because you sometimes find very eosinophilic abscesses. But in case of Kimura, also you find lots of eosinophils, and these eosinophils destroy the germinal center. You find classically a cervical lymph nodes with a serum Ig level increased. Here you can see here a follicular center, the eosinophils are entering. So there's a nice paper also you can go around. So confuses Langerhans cell histiocytosis, Hodgkin lymphoma, peripheral T-cell lymphoma, Kimura. So you need a clinical presentation and polykaryocyte for the diagnosis. So Kimura's disease. So this is a polykaryocyte. Okay, I'll conclude.
Sorry to interrupt you, Dr. Soumya.
Yes.
Yes.
Yes, Dr. Kaur, I think it's already too late. There are many cases, but it's not possible to discuss in one session. You should know the IgG.
Sir, we will arrange one separate webinar for you for the case discussions also. These are very interesting cases. The next speaker is waiting, so that's why.
Okay, no.
Sorry to interrupt you, sir.
No. There are other things like autoimmune disorder and this drug induced. You should know these cases. Thank you. These are my lymphoma lab people. Thanks, Dr. Kaur. I'll be happy to answer any questions if.
Thank you, Dr. Soumya Ranjan. And sorry to interrupt you in between. It was a very nice lecture, detailed lecture. Because sir, lymphoma, mimics of lymphoma are nightmares for all the pathologists, I think. So you have tried to discuss all the aspects, and now house is open for the question answer round. And if anybody has query, that can unmute his or herself and can ask question. I think our organizers have given this mode to the participants now. Otherwise, you can send your questions in the chat box also. Yes, there is one question. Okay, so people are appreciating you, but at present there is no question. We'll wait for 2-4 minutes for the.
There is one question from Dr. Meera.
Ji.
There's a question, madam. There's a question from Dr. Meera.
I have responded earlier also.
Okay.
Yes. Dr. Meera. That was the question, the same explanation was on BCL2, BCL6. I think sir has answered that question. Any new question? So I think that, yes. How to suspect lymphoma involving in background of ALP, sir?
So that's I discussed in my first slide only. In the background of ALP can progress to lymphoma. So once there is a lymphoma, you may not be able to identify the what's the background lesions. Like basically mostly happen in case of autoimmune disorders. Like you can have a autoimmune lymphadenopathy and that may progress to a lymphoma. So it doesn't matter when to suspect. That's the same criteria in the first slide. See the architecture. The criteria I told, the 10 criteria for architecture. Then your abnormal your IHC patterns. Then your distribution of IHCs. Then whether it is a kappa or lambda restricted, whether it is a then the clinical profile. That's the only. There is nothing extra I can say. You have to see the morphology. You have to see your IHCs. If it is a total obliteration, then architectural distortion, patient has a B symptoms along with your what called hepatosplenomegaly, then probably this is a lymphoma. And you should background ALP is mostly autoimmune conditions. You should keep in mind if an autoimmune condition examining ALP, you should first see whether it's a lymphoma or not.
Thank you,
I
sir.
hope this will.
Thank you, sir. Thank you, sir. Thank you for your presentation. You have spared your precious time in your busy schedule. Thank you very much, Dr. Soumya. Thank you.
Thank you, Dr. Kaur.
Now I request Dr. Jasmine Kaur, Assistant Professor Pathology, to introduce our next esteemed speaker, Dr. Jaspinder Kaur Bhatia, Professor and Head Command Hospital, Kolkata. She has worked as Professor, Armed Forces Medical College, Pune. Now over to Dr. Jasmine, please.
Good afternoon, everyone. Welcome again. Thanks you all for being with us. I would like to introduce our next prominent speaker, Dr. Jaswinder Kaur Bhatia. She is professor and head of Department of Pathology, Command Hospital, Eastern Command, Kolkata. She is recognized postgraduate teacher of Pune University, MUHS. She has special interest in oncopathology, molecular pathology, and cytopathology. She has more than 30 research papers in national and international journals, and she is a fellow of Indian College of Pathology. She has been awarded with Chief of Army Staff Commendation and with the Best Paper Award twice in year 2008-2009 in MJFI. Ma'am will enlighten us on ovarian tumors and immunohistochemical approach. We welcome you, ma'am. Please share your views with us. Thanks. Over to you, ma'am.
Thank you so much for this nice introduction. At the outset, I would like to thank the Professor Dr. D.K. Singh and Dr. Manjit for inviting me for this lecture. Let me see if I can do justice to the lecture. Am I audible?
Yes, ma'am, you're audible. Screen is visible.
Okay, thank you. So here we go ahead. The topic I have chosen is ovarian tumors, and I would be talking about the immunological or immunohistochemical profiling of ovarian tumors. As we all know, ovarian cancers account for a total of 3% of all cancers and 30% of all cancers of female genital system. However, a majority of the ovarian neoplasms can readily be organized by standard morphological examination using routine HNE. But significant problems may occur on morphology, and that's where the immunohistochemical markers come to being. Where do we use immunohistochemistry in ovarian tumors? Either to suggest or support a diagnosis. It acts as an important aid in differential diagnosis and is essential for diagnosis and classification of some metastatic tumors that involve the ovary. So we'll go one by one. This is a huge WHO classification 2020 of ovarian tumors. And the major classes of ovarian tumors are the surface epithelial tumors, the germ cell tumors, sex cord stromal tumors, and metastasis. So it's wise to kind of categorize these tumors into these 4 groups and then go ahead diagnosing these. The surface epithelial tumors are the most common, 60 to 70%. Germ cell tumors about 15 to 20%, sex cord stromal 5 to 10%, and metastasis in about 5%. This is the same representation of these tumors. As we all know, now ovarian serous carcinoma, instead of earlier when we would diagnose them as low-grade and high-grade carcinoma, now they are 2 distinct tumor types. It's not that the low-grade serous carcinoma progresses to a high-grade. They are 2 distinct types, and they are not 2 grades of the same neoplasm. They are different neoplasms with a different underlying behavior. And high-grade is much, much more common than low-grade. So these are the basic principles of going to diagnose ovarian tumors. The pathogenesis of both the tumors is different. The type 1 is a low-grade serous carcinoma, wherein it arises from a pre-existing benign and borderline tumors, and micropapillary variant of serous borderline may be intermediate in the development of low-grade serous carcinoma, and it follows a well carcinogenesis approach. Whereas the other type 2 is a high-grade serous carcinoma from the beginning. And the precursor lesion is in the fallopian tube, as we all know, is the serous tubal intraepithelial carcinoma. It does not arise from a borderline tumor. Starting with high-grade serous carcinomas, CK7, they're all 100% strong diffuse CK7 positive. There is a membranous positivity with EMA, and these are all WT1 positive in 90% of the cases. They will have a abnormal P53, ER positivity in 88 to 95% positive. PAC8 is positive, P16 is again strong diffuse, and there is a nuclear staining of PR is generally absent, and generally CK20 negative. So what do we have? We have a WT1 positive, P53 positive, P16 positive. To be considered significant, we need a WT1 nuclear staining, P53 staining, P16 staining. These are napsin A and HNF beta negative, which we'll come to later. Now, this is a high-grade serous carcinoma. You can see on morphology, these are high-grade nuclei, and you can see these slit-like spaces on morphology. As we go ahead doing a P53, this is again abnormal. We don't call P53 as positive or negative. We call them as abnormal or mutant. So here, this is a mutated P53 showing all positive, WT1 all positive, then CK7, CK20, and ER positive. CA125 is of limited value in these cases. This was actually a metastasis, so we've done CA125, WT positive, and ER positive. Low-grade serous carcinomas would be again CK7 positivity, and they show P53 wild type, and P16 shows a patchy positivity. This is again to show a high-grade serous carcinoma showing a diffuse positivity for P53. So in cases where we want to differentiate a low-grade versus a high-grade serous carcinoma, therein an aberrant P53 expression can be useful, as this pattern is consistent with a mutant P53 and supports a diagnosis of high-grade serous carcinoma. Coming to the interpretation of P53, this is known as the mutation type, wherein all the cells will be P53 nuclear positive. This is again a mutation type where it will be dead negative, in the sense that all the cells would be negative for P53. So herein you can see the positive internal control lymphocytes and fibroblasts, they show positive, and this is known as the wild type P53, which is seen in cases of low-grade serous carcinomas. So fibroblasts and lymphocytes act as an intrinsic control, and this is again a endometrioid low-grade serous carcinoma. Now, sometimes what happens is low-grade serous carcinoma mimics a high-grade serous carcinoma mimics a low-grade, showing these small papillae, and it looks like a low-grade, but an abnormal P53 comes to our rescue, and a P53 positive, strong diffuse P53 positivity makes it a high-grade serous carcinoma. Coming to P16, ovarian mucinous adenocarcinoma, you'll see only rare cells which are P16 positive. Endometrioid carcinoma, strong but incomplete positive for P16. Metastatic endocervical adenocarcinoma, again, strong complete staining in all cells, and a strong diffuse staining in ovarian serous carcinomas. Sometimes you have these low-grade serous carcinoma with large nuclei, and they somehow give you a impression of a high-grade tumor, but showing a wild-type P53 mutation. So you interpret it as, and plus other morphological features in other areas, you interpret it as low-grade ovarian serous carcinoma. Coming to the second surface epithelial tumor, that is the endometrioid carcinoma. These tumors are negative for WT1. So although 10 to 14% can express WT1, and they are negative for napsin A, which is around 3 to 8% positivity. These tumors are positive for CK and EMA, CK7 positive and generally negative for CK20. So one characteristic is they are diffuse strong positivity for ER and PR, and negative staining for WT1, P53 and P16 would favor a endometrioid carcinoma over a serous carcinoma. So when you want to differentiate endometrioid tumors, you should always, whenever you're trying to diagnose ovarian tumors, should always use a panel and use a one positive, which is expected positive, one negative, expected negative, and whatever you want to differentiate it from. So if you are wanting to differentiate it from serous carcinoma, you do a WT1, P53, ER, PR. So your WT1 will come negative, P53 will not be positive, and your CK EMA will be positive, and ER, PR will be positive. Also PR and vimentin. These tumors are vimentin positive. So they will be helping in differentiation from mucinous carcinoma. This is one endometrioid carcinoma. You can see these gland-like structures. It is a well differentiated. You're seeing these necrotic debris in the center and glandular structures. This is again membranous positivity for EMA and a diffuse nuclear staining for ER. These tumors are negative for P53 and vimentin positive. So you can diagnose an endometrioid carcinoma. Now, sometimes these sex cord stromal tumors also have tubules, and you need to differentiate these from endometrioid carcinoma. Here, positive staining for EMA and ER/PR can differentiate these from sex cord stromal tumors. Sex cord stromal tumors are either inhibin and calretin positive. So your endometrioid carcinoma will be CK-EMA positive, negative for inhibin and calretin. The granulosa cell tumor, this is part of the sex cord stromal tumors, will be again positive for inhibin and calret. Sertoli cell tumor positive for inhibin and calret, and Sertoli Leydig cell tumor positive, and Sertoli cell tumor again positive. So the panel which you apply here between endometrioid and sex cord stromal tumor would be your ER/EMA along with inhibin and calretin will help you differentiate it from a sex cord stromal tumor. WT1 staining, how do you see that? So here serous carcinoma will show a diffuse nuclear staining, and this would be lacking in a clear cell carcinoma and a endometrioid carcinoma. So WT1 will help you differentiate it from endometrioid carcinoma. P53 helps you differentiate a low grade from a high serous carcinoma. Now coming to Brenner's tumor. Brenner's tumor's immunohistochemistry is not very well characterized. However, these tumors are positive for CK7, P63 and S100, negative for CK20. This is in contrast to the TCC of the bladder. So that is one marker which can be helpful in differentiating a tumor originating from the urinary tract from the Brenner's tumor. And Paxate, ER/PR are negative, and these are negative for WT1, showing a wild type pattern for P53. The morphology is, you can see these transitional cells and is quite characteristic. Coming to another tumor which needs to be remembered and needs to be differentiated from other tumors is the clear cell carcinoma. These tumors are positive for napsin-A and hepatocyte nuclear factor 1 beta, and these are negative for WT1, ER and PR. So if we do a panel of WT1, napsin-A and ER for differentiation with high-grade serous carcinoma, we can help differentiate these clear cell carcinoma from high-grade serous carcinoma. And if you want to differentiate these from endometrioid tumors, we should do a panel of napsin-A and PR. These for differentiation with the endometrioid carcinoma. So these tumor cells show strong positive staining for CK, CK7, EMA, and these tumors are CK20 negative. ER/PR is generally negative in these tumors. These tumors are WT1 negative, ER negative, hepatocyte nuclear factor 1 beta negative, and napsin-A is positive in clear cell carcinoma. These tumors do not respond very well to conventional chemotherapy. So, hello.
Yes, ma'am, you are audible. You have
I think somebody muted me. So
ma'am, you are audible now. Yes. Sorry,
Yeah.
ma'am.
So we go back to clear cell carcinoma differentials are, again, it needs to be differentiated from yolk sac tumor, which I'll be coming to later. Now, yolk sac tumor also is positive for CK, negative for CK7 EMA, and it will be positive for AFP. And that is how you differentiate from, let me just go back to clear cell. Yeah. So these tumors would be negative for P53, WT1, and ER. And this is a panel showing the clear cell carcinoma. This is a tumor. As you can see, there's some kind of clear cells along with those hobnail cells, which are so characteristic and clear cytoplasm. These tumors are CK7 positive, hepatocyte nuclear factor 1 beta positive. And this is, again, you can see the positivity for napsin-A. Clear cell carcinoma differentials are yolk sac tumor. So we have a WT1 negative, ER negative, HNF1 beta negative. Now, there are some tumors which are totally undifferentiated. Here we want to differentiate these tumors, whether they are arising from high-grade serous carcinomas or what are these tumors. So sometimes they can show positivity for P16, WT1, and frequently for P53. And these are classified again as high-grade serous carcinomas. Now, undifferentiated tumors are those tumors which are malignant epithelial tumors which lack any evidence of any line of differentiation. Whereas dedifferentiated would be, you would find some kind of a differentiated area along with undifferentiated tumors. So these tumors can show sometimes EMA, pan-CK, CK18, PAX8, giving us some sign of high-grade serous carcinoma or arising from the ovary, and P53 is wild type in these tumors. Sometimes you have a small cell neuroendocrine type of pattern, which would be again positive for synaptochromo, or a lymphoma, which is again diffuse large B-cell lymphoma, positivity for CK20, CD20 can be seen. Coming to mucinous carcinoma. An improved understanding, we know now that there are mucinous carcinomas, reported incidence is now less, because the majority are known to be as metastatic carcinomas, and somehow the origin of as ovary has not been really proved. So for mucinous carcinoma, the stains which we use are CK720 and CDX2 are of great value in diagnosis of mucinous tumors. And staining of CK20 is generally present, but it's moderate and patchy. And CDX2 is also again patchy. So if you want to differentiate these tumors from the metastatic colonic tumors, colonic carcinomas would be CK7 negative and CK20 and CDX2 positive. So this is just a table from the WHO book showing the classification and the differentiation from various tumors. So you have the low-grade serous carcinoma, high-grade mucinous endometrioid and clear cell. So these tumors are generally PAX8 positive with less positivity of mucinous carcinoma. WT1 positivity is seen in low-grade, high-grade tumors and less in clear cell carcinoma, mucinous carcinoma, and clear cell carcinoma are again negative. This I've already explained. So when you want to differentiate mesothelioma from serous carcinoma, these tumors are mesotheliomas calretinine positive and ER and BROP4 again positive in serous carcinoma. Here, one thing which we should remember is that staining for WT1 is not helpful because this will be positive in both the tumors. So you start using a panel of markers. You use D240, BREP4, and this can help you differentiate from a mesothelioma. D240 is positive up to 20% of serous carcinoma also. So you use a panel. PAX8 is almost always positive in serous carcinoma and in about 20% of mesothelioma, which is weak and focal. So again, coming back to one point that we need a panel. You cannot just have one immunohistochemical stain saying and then coming to a diagnosis that it is this kind of a tumor. Coming to the next category, that is the sex cord stromal tumors. These can be either positive or negative for CK. This must be remembered, they're always EMA negative. So if you have endometrioid kind of tumor, you can differentiate with the help of EMA. A positive staining for EMA suggests an epithelial tumor. So either primary or metastatic, which is mimicking a sex cord stromal tumor. Calretinine is a sensitive marker, but it is less specific than another marker, which is inhibin. Inhibin is a relatively specific marker for sex cord stromal tumors. And then you can add on some other markers like CD56, WT1 nucleotides can be positive, and steroidogenic factor 1 or SF1. This is adult granulosa cell tumor. You can see these bodies and you can see the characteristic pattern and the grooving of the cells and a diffuse positivity with inhibin in these tumors. Now again, granulosa cell tumors are inhibin, calret, FOXL2, steroidogenic factor positivity and WT1 and CD56 positive. These would be negative for CK7 and EMA, maybe positive for SMA, desmin, CD99. I'll just show you one of the slides, and S100 positive. Calretinine also will be positive in other sex cord stromal tumors. So the two markers which we would do is SF1 and FOXL2 for specifically. So the panel here would be inhibin, calret, SF1, FOXL2 as positive markers, and EMA would be negative in granulosa cell tumors. Now, to differentiate these from carcinomas, carcinoids, lymphomas, and small cell carcinomas, you have the characteristic markers for lymphoma, for epithelial tumors, and the neuroendocrine tumors to differentiate it from these tumors. Juvenile granulosa cell tumor is typically CD99 positive. You can see this membranous kind of positivity here. These tumors are usually positive for inhibin, CalRET, SF1, CD99, and CD56, and small minority express FOXL2. EMA is only rarely weakly and focally positive in juvenile granulosa cell tumors. This is again Sertoli Leydig cell tumor. These are again positive for most of the broad spectrum keratins, inhibin, calretinin, and CD99, and again they are negative for EMA. You can see these tubules here, the Sertoli Leydig cell tumor, showing the inhibin positivity. And here, this is a membranous positivity for CD99. Coming to the next category of tumors, these are the germ cell tumors. Placental alkaline phosphatase is known to be positive, but this is not too specific. So PLAP is generally done along with other markers. We do it along with other markers which are specific for specific germ cell tumors. So these are OCT4, CD117, D240. These are the most useful markers for dysgerminoma. And OCT4 and CD30 are more useful for embryonal carcinoma. And we must remember that alpha-fetoprotein and glypican-3 are more useful for yolk sac tumor. EMA is again negative in most of the malignant germ cell tumors. So we have these markers. One is PLAP, second is OCT4, CD117, D240, and CD30, AFP, and glypican-3. So this is a panel of marker if you're suspecting a germ cell tumor. This is again this is a slide showing the dysgerminoma. You can see these large cells with prominent nuclei. PLAP positive, CD117 positive. This is again one more case showing CD11 positivity. SAL4 positive, OCT4 positive. So these would be your dysgerminoma panel. Next is your yolk sac. Yolk sac tumors are alpha-fetoprotein positive, glypican-3 positive. Then other tumors can also be, other markers can also be seen. However, these would be negative for OCT4, SOX2, DD40, and CD30. So you can see alpha-fetoprotein positivity. This is a yolk sac tumor showing AFP positivity. This was another case wherein we saw these cysts and showing the yolk sac component along with the embryonal carcinoma. And this part is the yolk sac component showing the positivity for alpha-fetoprotein. And this is showing, this is a mixed tumor showing positivity for CD30. So embryonal carcinomas are CD30 positivity. So typically positive for wide spectrum CKs, CD30, OCT4, SAL4, and glypican-3. And EMA is again positive. SOX2 is variably positive. So these are the differentials of germ cell tumors. Dysgerminoma will be PLAP positive. See, you can see that it's all the germ cell tumors would be PLAP positive. So it's difficult to differentiate these tumors in between themselves by using PLAP. So we use these markers. CKIT would be positive, or CD117 would be positive in dysgerminoma, OCT4 in dysgerminoma and embryonal, CD30 in embryonal carcinoma, and then these all will be EMA negative. And choriocarcinoma will be again beta HCG positive, P63, P40 will be positive. Yolk sac specifically will be positive for AFP, embryonal carcinoma, CD30 and SOX2 positive. Teratoma has very little role. Immunohistochemistry has very little role in mature and immature teratoma. GFAP you can use for staining the glial tissue, and TTF1 and thyroglobulin can pick up the thyroid. Chromogranin synapto will be positive for the neuroendocrine component. And if you want to differentiate it from colorectal tumors, you can do a CDX2. Now this is a struma ovari. You can see this is thyroglobulin positivity in a monodermal teratoma. Coming to mucinous carcinoma, these are diffusely positive for CK7, variably positive for CK20 and CDX2. CK19.9 is again diffusely positive. And these tumors will be CA125, WT1, napsin-A, vimentin, ERPR negative. Paxet will be focal and weak in these type of tumors. P53 wild type or can show mutation type staining also. and P60 is negative or focal positive. Another important component is differentiation of these tumors from metastatic tumors. Now, the most common tumor is the colorectal adenocarcinoma, which is the most frequent metastasis. This can mimic both, because glandular element is there, endometrioid and mucinous adenocarcinoma of the ovary. And the most useful stains for identifying these metastases, which the panel which we are using, are CK720 and CDX2. So primary ovarian carcinoma will usually be CK7 positive, 20 negative, and CDX2 negative. But primary mucinous carcinoma is again CK7 positive, can show positivity for CK20 and CDX2 also. So we must remember that also. Metastatic tumors are generally CK7 negative. Metastasis from colorectal adenocarcinoma are usually, but not always, CK20 positive. Biliary and pancreatic carcinomas would be CDX2 negative and DCP4 positive. That means DCP4 is deficient. This is again one chart showing a differentiation of the primary site of origin, and you use the common markers, which are CK7. This is the panel 20, CDX2 you can add along with that, and DPC4 for pancreatic carcinoma, which is deficient. Now, this is a panel showing endometrioid carcinoma, which is positive for CK7 and negative for CK20. So this is the endometrioid adenocarcinoma. This is a colorectal carcinoma showing 7 negative, CK20 positive, and CDX2 again positive. So this is ovarian mucinous carcinoma, diffusely positive for CK7, and focal patchy positivity. Even if it is positive, it's focal patchy for CK20. So this is how you can differentiate the primary from metastatic carcinoma. This is another case of metastatic breast carcinoma, positive for GCDFP15. Here you can say that, yes, this is coming from breast. So the panel of markers which we use for primary versus metastatic differentiation: CK7, 20, CDX2, ERPR, Paxit, which is a marker of Mullerian differentiation, CK7 negative, CK20 positive, CDX2 positive are indicative of a colorectal primary. Mostly left-sided are CK20 positive and 7 negative. And these 7 positive, 20 minus, Paxit positive, CA125. The utility of these two is limited, but if it is at a site which is away from ovary and you want to find the ovarian origin, yes, Paxit at times, though it's positive in other tumors also, it can help you in addition to other markers. And ERPR positive are indicative of an ovarian primary. So just to sum up, immunohistochemistry has had a major impact in these recent years and an aid to diagnosis in field of ovarian neoplasm. But a word of caution here that your panel should be very, very judiciously chosen. It's not that you put the entire list of markers for all the diagnosis. It has to, morphology has to guide the immunohistochemistry. Now, IHC panels should include markers which are expected to be positive and negative in various tumors for differential diagnosis, and no antibody is specific for any given tumor, and that unexpected positive and negative immunoreactions may occasionally occur. I stop here. Thank you so much once again, Professor Dr. D.K. Singh and Dr. Manjit, for having me over and inviting me for this presentation.
Thanks, ma'am. Thank you very much. Thank you very much for the elaborated lecture on the ovarian tumors. Now the house is open for the queries and questions. Ma'am, there is already one question in the question answer section. What is wild type P53? It's from Meera Radhakrishnan.
Yeah. So can you hear me? Yeah. So wild type is basically when we say mutant type, meaning it is 100% of the cells are showing nuclear positivity. And wild type is when you see some of the cells are showing positive, which are dark in color, some are slightly less stained, and some are unstained. Meaning it is all the cells are not stained. Diffuse staining is not there. Strong staining is not there. So normal, this thing would be wild type. unless it is mutated. Once P53 gets mutated, either all cells stain positive or all cells stain negative. And if all the P53, all the cells are negative, lining cells are negative, then you need to have a internal control which is positively stained. Otherwise, you interpret it as if the stain has not worked. So it should be either dead negative or all positive, then it's mutant. And wild type meaning which is normally available. It is not really mutated. So normal staining is P53 wild type, which is seen in a low-grade serous carcinoma. Is it okay? Is it okay?
Ma'am, there's a question from my side. When is there any cutoff criteria? You are saying that few cells are stained. So is there any cutoff criteria for this?
No, no, there is no. Thank you so much, Dr. Manjit. Thanks.
Ma'am, there is one more question. Wait, ma'am, please. There's
Yes,
one more question.
Sure, sure.
Yes. This is mucinous. Where is it? I think person has hide that question.
Okay.
Yes, again to yes. Question has been.
Okay, thank you.
Yeah,
Thanks.
thank you.
Thanks.
Thank you, ma'am. Thank you so much. Yes. Thank you, participants, to be with us and with your with patience and so much of interest. This in academic feast. Now I have another announcement. There will be a display of the posters for 20 minutes so that you can read, you can go through the posters which have been selected for the oral presentation. And at 2 o'clock, I think our team has communicated with the selected participants, and they should be ready at 2 o'clock, and team will allow them to unmute their self, and slide will be displayed by our side. So people are asking for laptop arrangement and other things. You don't have to arrange anything. Slides will be displayed by our team on the screen, and numbers has been given to you from 1 to 8, 1 to 8, and on your turn you know your numbers, and whenever there is your turn you can unmute yourself and you can answer the question and read the poster. Yes, there is one more poster, ninth number given to that, that has been selected and received late, so we will not include that participant in the competition. Means we will not give any first, second or third prize to the that participant, ninth poster, but we will include, we will allow that participant to present the poster. Okay, so thank you. You can remain logged in, and we will meet again at 2 o'clock. Thank you very much for your patience. Thank you very much. I request participants to remain logged in, and then we'll display the posters. Okay, you can join us at 2 o'clock. You can have your lunch, that is virtual lunch, and after that there will be round for the poster evaluation. Thank you. Yes, I'll again intervene. There are many questions in the chat box that will a recording of the session will be available or the slides will be available. You can check this on the YouTube channel. We have given link of YouTube channel also. You can go and check there. Thank you. Hello, Shama, are you listening?
Yes, ma'am.
Okay, yeah, few of the participants are saying that there is some problem in the network. Is there an issue?
No, ma'am. It might be from their side.
Okay. Diksha, are you listening me? You have sent a message that there is network problem. Can you send a message in the chat box?
From our side, it's not there. It's from the from their side, attendee side. You can see my slides, right?
Yes, I can see your slides, but these participants are sending message actually.
Yeah. So if you can see, then there is no problem.
Yes. Yes. Good afternoon, all. Welcome back to the first virtual CME of Department of Pathology and Lab Medicine, All India Institute of Medical Sciences, Bathinda. So, best of luck to all the participants who are going to present. And I request Shama to unmute the participant list.
Ma'am, they have to unmute from their side.
Okay.
So you'll have to ask them to unmute.
They can unmute, na? Okay, ma'am. Okay. Thank you. Thank you. Yes. So first poster presentation. Shama, please display first poster.
Yes, yes, ma'am.
Yes. Poster 1, please introduce yourself. Yes, Saurav, please unmute yourself. We will give you 5 minutes.
Have they unmuted, ma'am?
Pardon, ma'am?
Have they unmuted?
Yes, he have sent message. How to unmute?
They will be.
Ma'am, click the red icon on your screen.
They have to. We got to the panelist. What is the name, ma'am?
Saurav Saxena, ma'am. Saurav Saxena, he has raised a hand, but
Yeah, I have promoted him to panelist.
okay.
One by one, when there are poster presentations, you just keep me telling the names.
Okay, ma'am. Hello.
Yeah. Manjit, Saurav. Yes, present your poster now.
Good afternoon, ma'am. Myself, Dr. Saurabh Saxena. I am third year resident, Command Hospital, Central Command, Lucknow.
Dr. Saurav, hello. You just disconnect from the other. You're connected from 2 devices. Disconnect the other device, please.
Hello. Hello. Hello.
Yeah, now it's okay. I can hear you.
Yes, ma'am. Myself, Dr. Saurabh Saxena. I am third year resident, Command Hospital, Central Command, Lucknow, and I'm presenting a poster. The title is Secondary Hemophagocytic Lymphohistiocytosis, the rare etiologies of rare disease. The introduction part, ma'am, HLH, secondary hemophagocytic lymphohistiocytosis, is caused by uncontrolled T cell activation, hypercytokinemia, and exaggerated inflammatory response, and has an incidence of 1.2 cases per 10 lakh per year. Common associations are with autoimmune disease, malignancies, or infections, and the incidence of HLH with erythema nodosum leprosum, there are very few case reports. With Hodgkin lymphoma, it is 1%, and with SLE in males, especially, it is 0.9 to 4.6%. And the diagnostic criteria is based on HLH 2004 diagnostic criteria and the H score. I have 3 case reports. The first case report is a 30-year-old female presented at 36 weeks of gestation with high-grade fever, jaundice, and the ENL lesions on extremities and face, and ascites for 10 days. Lab investigation shows biocytopenia, increased ferritin level, increased SGOT level, increased triglycerides, and total cholesterol. And the D-dimer level were also raised. CCT showed splenomegaly. The bone marrow aspirate and bone marrow biopsy showed evidence of hemophagocytosis. The H score was 212 and the cutoff is 169. So she was diagnosed as a secondary hemophagocytosis, HLH syndrome. And the treatment, the IVIG was given for 5 days along with injection dexamethasone, and the patient recovered well. The case report 2, it is a 31-year-old lady already diagnosed as a case of Kikuchi-Fujimoto disease 1 year back based on lymph node biopsy. She presented with fever, progressive cervical lymphadenopathy, and abdominal distension since 1 month duration. And on clinical examination, there was hepatosplenomegaly was present. Lab investigation showed pancytopenia, deranged LFT, increased ferritin level, decreased fibrinogen level, and this hypertriglyceridemia. Cervical lymph node biopsy shows Hodgkin lymphoma with evidence of hemophagocytosis, and the bone marrow aspirate and biopsy showed evidence of hemophagocytosis, but not involved by lymphoma. The H score was 286 points, and she was diagnosed as a case of Hodgkin lymphoma with secondary HLH. And case 3, a 30-year-old male presented with fever, lethargy, jaundice since 1 month with facial hyperpigmentation. There was no hepatosplenomegaly, but the lab investigation shows pancytopenia, deranged LFT, increased ferritin level, increased triglyceride, and the urine protein creatine ratio was 2:1, which was raised. USG shows increased bilateral kidneys. However, liver and spleen were normal in size. The autoimmune workup showed anti-dsDNA antibody and ANA antibody were present. Bone marrow biopsy shows HLH, and the treatment, he was diagnosed as secondary HLH with SLE, and treatment IVIG was given along with steroid. However, flash pulmonary edema he developed with deranged RFT, and he's come to sepsis. The figure 1 shows the ENL lesion on the face. Figure 2 shows lymph node biopsy showing Hodgkin lymphoma with hemophagocytosis. Figure 3 is of the bone marrow aspirate showing hemophagocytosis, and the figure 4 is a hyperpigmentation on the face of the male with SLE. So, ma'am, the conclusion is that we have to be very careful in the cases presenting with multi-system involvement and cytopenias. So there's a high index of suspicion of HLH, and clinical diagnosis of HLH is a double-edged sword in immunocompromised patients and in sepsis because they mimic each other. HLH 2004 criteria shows 95 sensitivity and 93.6% specificity, and H score shows 100% sensitivity and 94.1% specificity in the diagnosis of HLH. Hello.
Yes, I'm listening to complete.
Ma'am, completed.
I think that's all. Saurabh?
Yes, ma'am.
I request Dr. Jaswinder, ma'am, do you want to ask anything to the presenter?
Yes, Dr. Saurav, can you just please elaborate what is H score and how did you come to the diagnosis of HLH in these cases?
Ma'am, H score is for reactive hemophagocytic syndrome, and it involves 9 points. First is underlying immunosuppression, is it present or not? Second is the temperature, is it less than 101.1 or more than 101.1? Then is there any organomegaly not present, or if there is both hepatosplenomegaly or splenomegaly? Then number of cytopenias present, then the ferritin level less than 2000 to 6000 and more than 6000, the triglyceride level less than 132.7 or more than 354 milligram per deciliter, the fibrinogen level less than 2.5 or more than 2.5 gram per liter, and the AST is unit per liter less than 30 or more than 30. And on bone marrow biopsy, is the hemophagocytosis present or not? So we have to give the points according to that, and the cutoff point is 169, which gives the probability of how much the chances of getting HLH syndrome.
Good. That's a nice answer, Saurabh. And how do you morphologically suspect HLH on histology?
Ma'am, on histology, we'll see the hemophagocytosis or platelet phagocytosis will be present. There will be more of macrophages, and histiocytosis will be there. And we can prove it by IHC marker like CD68, CD163. And ma'am,
Good. Well done. Yeah.
Yes, ma'am.
I will introduce our second judge, Dr. Anuradha Rash, Associate Professor and in charge of Department of Ophthalmology. Ma'am, would you like to ask anything?
Yeah, I want to ask Dr. Saurabh. It's a
Yes,
good
ma'am.
presentation. I just want to ask because first case it was in this pandemic only.
Ma'am, she was a pregnant lady.
This was in pandemic. Okay, viral markers as well as COVID-19 test was done for that first case.
No, ma'am. Sorry to say, but it was prior to the pandemic ma'am, time.
Okay, but I think viral marker was also required in this first case because
Okay.
of all the symptoms which were quite catchy of that. If it could have been in this era, then COVID-19 test was also
Okay.
recommended.
Ma'am,
That's
actually,
why I
viral markers were done, but they were all negative, ma'am.
okay, because you have not mentioned that. Okay,
Yes, ma'am.
thank you.
Thank you, ma'am.
Next is Dr. Jaspreet Shedgul, in charge of surgery unit. So would you like to ask anything? So please unmute your mic. So please unmute your mic and
Yes, Dr. Saurabh, I was
Yes,
going
sir.
through your case reports.
Yes, sir.
Your case 1 and case 3, you have examined the patient by CCT abdomen and ultrasound abdomen, whereas you have not conducted any ultrasound abdomen for case 2. And in your complaint, you have suggested that patient had abdominal distension also. Could you explain why? Dr. Saurabh?
Dr. Saurabh sir, you are on mute.
Dr. Saurabh?
हमने नोड्यूल लिखा है ना अपना, इसमें तो दिया enlarging erythematous patch होता है.
Hello.
Hello.
Sir, there was actually hepatosplenomegaly was present and ultrasound was conducted, but I had not mentioned in the poster, sir. I just written hepatosplenomegaly.
That was to evaluate, when the patient you have mentioned in clinical findings of abdominal distension, so that has to be diagnosed. What was the underlying pathology for that? So in all the cases, the patients had hepatosplenomegaly.
Sir, in the first case, the splenomegaly was present. Second case, hepatosplenomegaly, and in the third case, there was no hepatosplenomegaly, sir.
But in your ultrasound report, you mentioned that in third case also.
Sir, in third case, their bilateral kidneys are increased, but there was no hepatosplenomegaly present, sir.
Right. And what was the, how do you correlate this thing with the other two cases?
Sir, pardon, sir?
How you correlate that it was no hepatosplenomegaly in the third case, whereas it was present in the case 1 and case 2?
Sir, in case 1 and case 2, patient was evaluated on CCT and ultrasound. They were present hepatosplenomegaly.
That I have read. What I want to say is, why is this differential finding in this case, whereas you had the organomegaly in the first two cases?
Sir, there will be difference in the H score, sir. He was diagnosed as a case of SLE with hemophagocytosis, so kidney was increased, but sir, there was no increase in the size of liver and spleen, sir. So the H score will vary accordingly, sir. The H score is 226, sir.
If we see in case 1, the H score is 212, and case 2 is 216.
Sir, because there are certain other factors like this pancytopenia is present, sir. Serum ferritin level is present. So accordingly, sir, as per criteria, sir, I calculated. So the H score came out to be
right. Okay, thanks.
Right. Thank you, sir.
okay. Dr. Saurabh?
Yes, ma'am.
There was question in the chat box. How was the response to the treatment?
Ma'am, the case 1, she responded well, but case 2 and case 3, they succumbed to sepsis. However, they initially responded well, but after some time they succumbed to sepsis because there was neutropenia in the second case, and in third, the patient had flash pulmonary edema and cardiopulmonary arrest and sepsis, ma'am. So only the first case she survived well, and she is performing well till now, sir.
Okay, okay. So our fourth judge is Dr. Sanjay Kumar Rajput, Associate Professor and in charge of the Department of Biochemistry. So as of now, there is no question from his side. Thank you,
Yes,
Saurabh.
thank you, ma'am.
Ms. Shama, can you present second poster? Yes. Prabhat?
मैम मैंने चेक कर लिया, अभी गाड़ी में तो नहीं है, फिर वो क्रॉस में जाके ऐसे ही मैं लेट हो गई थी मैम। अभी क्या है, मेरी 4 बजे से ड्यूटी है कोविड में, अगर मैं रूम पे गई और
Dr. Prabhat, are you listening me? Shama, please add Dr. Prabhat in the panelist list so that he can unmute himself.
They are already added in the panelist list. He has to unmute.
Prabhat, please unmute yourself. Dr. Prabhat Sharma? Yes.
Yeah, he has unmuted.
Yes. Start.
Dr. Prabhat, you can speak. Dr. Prabhat, you can speak.
Yes, he has unmuted himself. Dr. Prabhat, are you there?
Sir, we cannot hear you. Your voice is not audible. He's speaking, but I think so with his microphone. Dr. Prabhat, can you just remove your microphone and try to speak?
Dr. Prabhat, please type in the chat box what problem you are facing.
Dr. Prabhat, you can send your message in the chat box, and Shama, please move ahead towards the third.
He's saying I'm doing. He's saying I'm doing. So can we do this later afterwards, Dr. Prabhat?
That's what I'm saying. We can do it later. Let him get settled. Okay. Move on to next. Monica. Yes, Monica Puri, are you listening?
Yes, ma'am.
Yes, start your poster.
Okay, ma'am. Good afternoon, everyone. Myself, Dr. Monica Puri, PG resident, second year, Maharshi Markandeeshwar Medical College and Hospital, Kumar Hatti, Solan. I am presenting a rare case of pigmented Bowen disease. There was a 60-year female presented with hyperpigmented and hyperkeratotic nodule on the perianal region and pain for 3 months. Clinically, the lesion was suspected as seborrheic keratosis, viral wart, and basal cell carcinoma, for which excisional biopsy was planned by a clinician to rule out the differentials and make the diagnosis. Biopsy was processed in our department, and on microscopy, we found marked hyperkeratosis, parakeratosis, marked...
Sorry to interrupt you, Monica. Sorry to interrupt you. Please discuss your findings and discussion.
हाँ जी मैम, on microscopy. On microscopy, we found marked hyperkeratosis, parakeratosis, acanthosis, and papillomatosis. There was loss of polarity of keratinocytes, mild to moderate nuclear atypia, mitosis, and abundant melanin pigment found in the basal layer. Papillary dermis showed increased melanophages and chronic inflammatory infiltrate. Reticular dermis was unremarkable. On the basis of above findings, we excluded the other differential and proceeded to make the diagnosis of pigmented Barn disease. It was reviewed in the literature that this pigmented Barn disease is a rare variant uncommonly found in perianal region. Thank you. And in my pictures, I have described, first picture I have described in my first scanner view under HND. I have described this hyperkeratosis, parakeratosis, acanthosis, and papillomatosis. In my second picture, I have shown the areas of ulceration. In my third picture, I have shown mitosis. In my fourth picture, that is D, marked atypia in all over in the keratinocytes, mild to moderate nuclear atypia, and in my fifth picture, I have described pigmentation. Thank you.
Monica, now that you're showing a slide showing papillomatosis, acanthosis along with pigmented cells.
Yes, ma'am.
There is atypia in the epidermis and you are seeing a few nests of cells showing pigment.
Yes,
what are the other malignancies which you need to rule out in these cases? What would be differentials here?
Yes, ma'am, I can hear.
I'm asking you what are the differentials here in this case?
Ma'am, in these differentials, I have to rule out melanoma in situ, other pigmented lesion like basal cell.
Melanoma. How will you rule out melanoma in these cases?
Ma'am, in melanoma, actually the cell morphology of cell itself, and we will get if atypia is present, that is located only in the basal layer we will find.
Any immunohistochemical markers you can do?
On immunohistochemistry, we can differentiate it by using Melan A, HMB 45, S100.
Which is the specific marker for melanoma, Monica?
Ma'am, HMB 45.
No, is it more specific than Melan A?
Yes, ma'am.
No, Melan A is more specific, okay? HMB 45 you can see in other malignancies as well. Okay, and how do you rule out a squamous cell carcinoma in this?
Ma'am, it is squamous cell carcinoma in situ only, na? Barn disease.
So for squamous cell carcinoma, you need to take more sections and to rule out invasion. Okay?
Invasion, yes, ma'am.
Carcinoma in situ, okay?
Yes, ma'am.
Yeah, so you have to look for invasion at any place and rule that out, okay? Yeah.
Okay, ma'am.
Okay, Monica, thank you.
Thank you, ma'am.
I had a question for the previous. Hello.
You're audible, sir.
Ma'am, I had a question for Dr. Monica. Is she there?
She's there.
Dr.
She's
Monica,
there, sir. Ask question.
Dr. Monica, what is the percentage of basal cell carcinoma in the perianal region?
Dr. Monica, please unmute yourself. There's a question for you from Dr. Shergill.
Ma'am.
Dr. Monica, can you tell me the percentage of basal cell carcinoma in perianal region?
Sir, your voice is a little bit very low. I am not able to hear clearly.
Can you tell me the percentage?
Monica, percentage of basal cell carcinoma in perianal region.
Hanji.
What is
How
the
to
percentage?
differentiate that? Hello.
Sir is asking what percentage incidence or prevalence of the BCC in near the anal region.
Prevalence of BCC, ma'am.
Yes. Okay, no problem. Dr. Shergil, do you have another question?
Right, ma'am, we can move to the next participant. We can move to the next participant, ma'am.
Okay, okay. Okay.
Okay.
Monica, this question in the chat box, was HPV done in this case?
What, ma'am?
HPV was done? P16 was applied or not?
No, ma'am. Ma'am, we don't have in our college.
Okay, okay. Okay.
Okay. Thank you, ma'am.
Okay. Now Prabhat, are you there now? Ma'am?
Yes, ma'am. I am audible now?
Shama, yes, you are audible. Shama, please move to second poster, Dr. Prabhat.
Sorry for inconvenience. Myself, Dr. Prabhat. I am working as a concerned pathologist in Shelby Hospital, Ahmedabad. Today, my poster topic is platelet indices as a marker of severity in COVID-19 illness. The basically COVID-19 infection is globally pandemic declared by WHO in March 2020, which is present as a various clinical symptoms from ranging asymptomatic case to severe pneumonia. Complete blood count and coagulation workup, basically D-dimer, from primary set of investigation to add the diagnosis. However, platelet indices and their role and their correlation with the severity is yet to be explored. So the objective of my poster to study platelet indices and its correlation with the severity of COVID-19 illness. So we conduct a retrospective study. All the admitted RT-PCR positive patients in our hospital and see the disease outcome by utilizing server platelet indices marker. The clinical data was retrieved from the case record and cases was categorized as a mild, moderate, severe and critical based of clinical guidelines. Hematological parameters studied were platelet count and platelet indices such as platelet rate, platelet distribution width and mean platelet volume. Each of the parameters were correlated with the severity of disease and statistically analyzed by software. In our study, the mean age is 53.3 years, out of which 68% of cases are male. Out of 100 cases, 47% patients categorized as a mild, out of which 31 are male and 16 were female. 35% cases are moderate, out of which 24% were male and 11 were female. And out of 12 severe cases, 9 were male and 3 were female. And 6 with critical COVID illness, out of which 4 are male and 2 were female. Now the table 1 show the different platelet indices such as MPV, PDW, PCT, and how I see that all the platelet indices increased with the severity of COVID illness. Now the discussion part is that how it is possible that all the platelets including MPV, PDW and PCT increase with severity. So the mechanism of change in the platelet index in COVID-19 patient is probably multifactorial. 3 hypotheses related to platelet count and structure are proposed in COVID-19. Firstly, thrombocytopenia possibly due to the infection of bone marrow. Secondly, platelet destruction by immune system. Thirdly, platelet consumption due to aggregation in lungs. So at the result, platelet count decrease. So more platelet production produced by bone marrow. So an increased number of young platelet also functionally more active than the old platelet. These change may explain the increase in the platelet indices and in MPV, PDW, and PCT. So the conclusion is that platelet indices such as MPV, PDW, and PCT are the good guide for predicting the severity and disease outcome of COVID-19 illness. Thank you very much.
Very, very nicely presented, Dr. Prabhat, and it's a very timely kind of study.
Yes.
I have a few additions to make in the sense that when you're studying platelet
Indices.
And indices, it's better if you want to use these as a markers of prognosis. What you can do is you can add on to this study by having a kind of a timely platelet indices, in the sense is that you do one at admission, then you do at around say 2 weeks, then you can follow these patients up, and you can see the recovery, like the patients who are recovering and the patients who are actually dying, and the difference between them. It is a significant. And secondly, you can also find a cutoff value that yes, these are the people who are going to be, you know, recovering, and these are the people who are going to go, the prognosis is bad, and you can just compare them, and that will add value to your study. That is my submission. And secondly, because the pandemic is ongoing and any kind of research is welcome, I would again, once again, congratulate you on this. And secondly, I think you can add on and follow up these patients and increase the number of cases that you are doing. And there are a lot of studies that are coming up on platelet indices. And congratulations. Yeah.
Thank you. One thing, ma'am. Actually, I am looking for publication on this. But in the meantime, as I seen the poster presentation in this, so I collect only 100 cases, which is possible in short time.
Yes,
so,
that's
yes.
So you have more cases. You can
add
the cases. And okay, just one small question. What is NLR, and what is the significance? How are you finding in your cases?
Actually, NLR ratio is more than 3.3 in our study, is predicting the severeness or critical COVID illness patient.
Yes. So how does that stand with platelet indices? In the sense that if you add on that value, because NLR
because we are conducting study on NLR, PLR, platelet indices, and WBC histogram in COVID patient.
Okay.
So we can merge all these three or all these parameter.
Absolutely.
With
that add value to your study. You can add.
And we collect around 500 cases up to now, and some parameter are still going on. So that let's see what will happen.
Yeah, there's a question in the audience. I think I can just. If it permits me, I can just read it out.
Sure.
How are patients classified as mild, moderate, and severe, and on what?
These are the basically guidelines issued by Ministry of Family Healthcare in Gujarat. Mild case with includes their only upper respiratory tract infection. Moderate case basically pneumonia with SpO2 around 92 to 95. Severe case severe pneumonia with SpO2 less than 90, and critical case in ICU with severe pneumonia and other comorbidities like sepsis and other things.
Okay, there are more questions.
Yeah.
There's one question. These platelet changes are also seen in DIC and terminal critical illness. Please explain, are these changes specific to COVID?
These platelet changes are also seen in DIC, but not in prominent fashion. We see lot of case in which MPV increase in DIC, and PCT increase in DIC, but PDW might be normal or increase in our study.
Okay. There's one more question from Dr. Anu Sharma, MM Medical College Hospital, Solan. He's faculty member there. His question is on platelet indices in COVID-19. How did you exclude the confounding effect of sample collection of platelet parameter?
Actually, all the admitted patient and all the collection are done by vacuum and experienced dedicated phlebotomist by the hospital. So the pre-analytic error are causing effect on the these platelet indices are minimum.
Okay. Any more questions? Please, Rana ma'am and Shelby sir, any questions?
I want to congratulate Dr. Prabhat.
Thank
I
you, ma'am.
tell you one thing more. If this kind of study you have already done very well, but if clinicians they are added to it, and the clinical manifestations along with these indices,
Yeah,
if you, in further studies maybe
yeah.
if you
Ac-
correlate both these things, clinical manifestations
ac-
along with these platelet indices, that
Actually,
is
ma'am.
very
Actually,
that
ma'am.
is good and that
My
will
my
be useful also.
Actually, my co-author, Dr. Kapil, he is constant pulmonologist in our hospital, but now
Yeah.
he's suffering from COVID, so admitted at present now.
Okay. Okay.
So we are correlated with these study on oxygen supply also, and how much oxygen required. Uh, we set up cutoff value of 5, 10, and 15 liter
Mm-hmm.
per day.
Okay.
So there are a lot of things, but due to this sudden illness of my colleague, uh, we wait for some time.
Maybe some in other subset of study you can plan out like this, because there are multiple
Yeah, yeah,
involvement in COVID-19. So
yeah.
with this platelet
Yes,
indices, if you correlate and you will come out with a good result, that will be a good publishable material you will be having.
yeah. Yesterday I found one case of post-COVID recovery. Platelet count less than 10,000 and hemophagocytosis are seen in this case with mega karyocyte proliferation.
Okay. Okay. Congratulations. Good.
Thank you, man. Thank you.
Thank you.
Dr. Sanjay, would you like to ask any question on COVID? Dr. Jaspreet? Anyways, any question from the audience? Okay, thanks, Dr. Prabhat. It was a nice presentation. Next is Dr. Sarita, poster number 6.
Hello.
Yes, Dr. Sarita Soni.
Yes, ma'am. Good
Yes,
afternoon, ma'am.
yeah, good afternoon. Ms. Sharma, please display poster number 6. Dr. Sarita. Poster number 6, ma'am. Yes. Yes, Dr. Sarita.
Good afternoon, everyone. Topic for today's poster presentation is diagnostic utility of fine needle aspiration cytology in non-neoplastic nodular skin lesions with histopathological correlation. So I myself, Dr. Sarita Soni. I have done my post-graduation from Indira Gandhi Medical College. Am I audible?
Dr. Sarita?
Ma'am, am I audible?
Yeah, you're audible. Just volume is low. Please speak loudly a little bit if you can.
Okay. Now first is the introduction. Non-neoplastic nodular skin lesions result from inflammatory and infectious causes such as bacterial, viral, and fungal infection. Now the aims and objective. This study conducted to evaluate the efficacy and diagnostic accuracy of FNAC in non-neoplastic skin nodules. Now material and methods. Total 35 cases presented clinically with skin nodule were assessed by fine needle aspiration cytology. Slides of FNAC stained by Jimza staining, followed by biopsy. And slides of biopsy, they are stained by hematoxylin and eosin staining. And special stains are used wherever required. Now, efficacy and accuracy of FNAC were determined using histopathology as a gold standard. Now results. 65 out of 35 cases, 65.72% cases were infectious and 34.28% were non-infectious skin nodule. The most common infectious lesion was granulomatous dermatitis, that is in 52.18%, followed by cutaneous leishmaniasis, lepromatous leprosy, borderline tuberculoid leprosy, erythema nodosum, and sporotrichosis. The most common non-infectious lesion was epithelial cyst, followed by ganglion. There was 100% cytohistopathological correlation were obtained in 7 cases of granulomatous dermatitis, 5 cases of cutaneous leishmaniasis, 2 cases of lepromatous leprosy, 1 case of borderline tuberculoid leprosy, and epidermal cyst and ganglion. In 5 cases of granulomatous dermatitis, they were further subcategorized on histopathology as 1 case as cutaneous leishmaniasis, 1 case lepromatous leprosy, 1 case borderline tuberculoid leprosy, and 2 cases of sporotrichosis. Now, finally, FNAC had a sensitivity of 80%, specificity of 100%, and diagnostic accuracy of 93.8% in non-neoplastic nodular skin lesions.
Okay, Dr. Sarita, nice presentation. Now,
next discussion. The study included 65.72% of infectious and 34.28% of non-infectious nodular lesions, which was comparable to study done by Chauhan P. et al. Sensitivity of cytology in the detection of LD body was 83.3%, which was much higher than study by Chauhan P. et al. Now, the diagnostic accuracy of leprosy was 60% study by Jaswal et al. Finally, the sensitivity, specificity, and diagnostic accuracy of non-neoplastic nodular skin lesions were 80%, 100%, 93.8%, which were comparable to study by Chauhan P. et al. FNAC is a safe, rapid, cost-effective, well-tolerated diagnostic procedure and useful for the evaluation of non-neoplastic skin nodules with high sensitivity, specificity, and diagnostic accuracy. And there's a good correlation between cytological and histological features of skin nodule. Thank you.
Any questions, please?
Sorry. Next slide, please. One more slide. Yes. First photograph is for acid-fast bacilli. These are the rod-shaped organisms seen in the entire slide. They are stained by modified Zn under oil immersion. This is the photomicrograph of acid-fast bacilli stained by modified Zn under 100x on biopsy slide. And now this picture shows leishmaniasis. These are the oval-shaped structures which are seen inside the histiocyte, having one oval-shaped structure and a paranuclear bar-shaped kinetoplast. So this is LD body in Giemsa stain under oil immersion. And this is a photomicrograph showing histiocytes, and inside the histiocytes, these are the double dot LD body which are seen under oil immersion. Thank you.
That's all, Dr. Sarita. Jaswinder ma'am, would you like to ask anything?
Yeah, Dr. Sarita, nice presentation.
Thank you.
Very nicely presented also. I just have a question. Just a simple clarification if you can give me. How do you, what is the difference between modified Zn and Zn?
Hello?
What is the difference between a modified Zn stain and a Zn stain, which is done for tubercle bacillus?
Ma'am, Zn stain we do for tuberculosis, and
Yes.
modified Zn is done for leprosy.
What is the difference?
Ma'am, regarding the percentage of in 1%, In leprosy, we used 5% 5% acid stain, and whereas in case of tuberculosis, we use 20%.
Okay. And what is the difference in the morphology?
Ma'am, in
what are globi?
Ma'am, globi we seen in the case of leprosy, lepromatous leprosy, in which they are seen like the pack of cigarette.
They are seen like hay, isn't it, in the cells? Okay. Now, one more thing I just want to advise you. Whenever you're presenting a poster,
yes, ma'am,
pictures can be incorporated. Like poster is different from a written, for other presentees also. Whenever you're presenting a poster, these pictures can be incorporated in the text, and you can reduce the text a bit.
Okay, ma'am.
Like a poster, isn't it? Okay, Sarita.
Ji, ma'am.
Okay, well done. Yeah, thank you.
Thank you, ma'am.
Dr. Jaspreet, would you like to ask something?
Ma'am, let's move to the next participant. Done from my side.
Okay, sir. Another ma'am, Sanjay sir, would you like to ask?
Oh, it's okay. Thank you.
Okay, ma'am. Okay. This question for you, Dr. Sarita. How was this chorotrichosis diagnosed?
Ma'am, in the histopathology, we can see there is epidermal hyperplasia along with acute and chronic intense inflammatory infiltrate and neutrophilic microabscesses in the epidermis.
Okay. Okay, thank you, Dr. Sarita. Shama, please display poster number 4, Dr. Mehak. Dr. Mehak, start presenting your poster.
Hanji, good afternoon, ma'am.
Good afternoon.
Ma'am, may I start?
Yes, you should start, and please, as Dr. Jaswinder madam has instructed, please brief your poster. Don't read each and every line.
Ma'am, may I start?
Yes, yes, start.
Ma'am, there is disturbance.
You can start. We are listening. Your voice is clearly audible.
Okay, ma'am.
Yes.
Okay, ma'am. Good afternoon, everyone. Myself, Dr. Mehak. I am a second year resident at Maharishi Markandeshwar Medical College and Hospital, Solan. My case is a 72-year female who had an ovarian mass. CA 125 levels were raised. Total abdominal hysterectomy with bilateral salpingo-oophorectomy was performed. The gross specimen received had variegated appearance, and on microscopic examination, it was a biphasic tumor. The mesenchymal component showed predominantly spindle cells with marked nuclear pleomorphism. Binucleated and multinucleated tumor giant cells were also seen. There was extensive myxoid degeneration, and focal chondrosarcomatous component was also noted as seen in the second picture. The epithelial component was present in form of sheets, glandular pattern, and reticular pattern. This is seen in slide number C and D. Tumor cells were markedly pleomorphic with focal hobnailing. Samoma bodies were present as seen in slide A, and hyaline globules as seen in slide number C were seen. Mitotic activity was brisk, and bizarre mitotic figures were also noted. The initial examination looked like yolk sac tumor, but alpha fetoprotein levels were normal, and further extensive sectioning when done, it revealed more of epithelial component. So a final diagnosis of malignant mixed Mullerian tumor of ovary was rendered. And so we concluded that mixed germ cell tumors are common in young age, but there are few cases reported in postmenopausal women also. Yolk sac tumor shows wide range of histological patterns like microcystic or reticular, endodermal sinus, solid, glandular, papillary, macrocystic, hepatoid. And so it can mimic clear cell carcinoma or even endometrioid carcinoma. So serum alpha-fetoprotein and immunohistochemistry can be useful in such cases to differentiate between the two. Thank you.
Okay. Nice presentation, Dr. Mehak.
Thank you, ma'am.
Over to judges. Would you like to ask any question, please?
Dr. Manjit, I would like to ask Dr. Monica about this.
Yes, sir?
Am I audible?
Yes, you are audible.
I would like to ask Dr. Mehak, what is the most common?
Thank you, sir.
What is the most common germ cell tumor type? What is the most type?
So what is the most common?
Type of germ cell tumor.
Sir, dysgerminoma.
It could be yolk sac also.
So I think it's most common is germ cell tumor.
The malignant potential.
Sir, pardon?
Malignant potential.
Of, sir?
Of the yolk sac tumor, na?
Sorry, sir, I don't know. So it is malignant, highly malignant.
It's fine. Thank you.
Okay, sir.
It's highly malignant, na, Mehak?
Highly malignant, ma'am.
Highly malignant, yes.
And
Ajay, would you like to ask anything or should we go ahead?
I wanted to just add on. So you did not do any immunohistochemistry in this case?
ma'am, IHC is not in our college, ma'am.
Okay, doesn't matter. Just one
Hanji.
addition that this MMMT, the word, now it's we are using carcinosarcoma.
Carcinosarcoma, hanji, ma'am.
The latest classification includes the term carcinosarcoma
Carcinosarcoma.
rather than MMMT. Okay.
Hanji, hanji, okay.
Okay. Yeah.
Okay.
Any question? Yes, there is one question. Yes. Any IHC? This question in the chat box. Any IHC? So you have given already answer. So you have not done any IHC on it, no?
No, ma'am.
Yeah. Any question, Namrata ma'am, Dr. Sanjay sir?
Yeah, I want to ask one thing.
Hanji.
What is the follow-up available with you for this patient till now? How much follow-up you have with this patient, or you don't have any follow-up?
No, ma'am, we don't have any follow-up.
Because I wanted to know the prognosis of this patient.
No, ma'am, we don't have any follow-up.
Okay. Thank you.
Okay,
If
thank
never happens to avoid of this patient marriage, then try to follow.
Okay, ma'am.
Yeah, try to follow.
Okay, ma'am.
Now, I think for one post-hospitalization more, 1 and 2, 8 and 9. Moving on to post-hospitalization number 8. Uttam, Dr. Uttam. Shama, please move on to poster number 8 as 5 and 7 are not there. Move on to 8.
Am I audible, ma'am? Am I audible?
Yes, Uttam.
Yes, ma'am. Good afternoon, ma'am. Okay. Can I start now?
Yes, you can start and it will loud.
Okay, ma'am. Good afternoon, one and all present here in the first virtual CME of Pathology. Myself, Uttam Sharma from Central University of Punjab, Bathinda, and I am presenting before you my recent findings on microRNA 320A in lung cancer. So the title of my study is Clinical Pathological Impact of Circulating microRNA 320A in non-small cell lung cancer. Let us start with a brief introduction of microRNA. MicroRNA are endogenous small non-coding RNA molecule which can be secreted into a circulation and remain exist in a stable form. Just like intracellular microRNA, circulating microRNA participate in various biological processes and expressed aberrantly under abnormal or pathological conditions. So the previous report suggested that this quantity and quality change of circulating microRNA associated with the initiation and progression of cancers, including NSCLC, is a non-small cell lung cancers, and these molecules can be detected easily by various molecular techniques. So with this background, we hypothesize that there would be a possibility to have a linkage between a microRNA 320A and NSCLC patients. Next slide, please. So the lung cancer, as we are all aware that this lung cancer ranks top in the form of incidence and the mortality rate. However, despite the development of molecular techniques for diagnosis and the treatment strategy, still the 5-year survival rate of the lung cancer patient is less than 15%, which is unacceptable in the current advanced scenario. But unfortunately, the acquired symptoms during cancer initiation is often coincide with the other respiratory diseases, and by the time patient understood that he or she has a tumor, the tumor already reached to a certain advanced stages and metastasized to other organ. So at that time, the immune system of that particular patient is already weak, and the patient is also very like pathological condition of the patient is very poor. So in that particular time, if the tissue biopsy or the bronchoscopy was done on that particular patient, there would be a more invasive and painful for them. So the idea was that why not to develop or identify such molecular marker which is present endogenously in our body and also in the circulation, and during the pathological condition in cancerous condition, this molecular marker can be altered and we can identify it by taking a blood samples. So with this theme, we propose certain objectives. First is the expression profiling of microRNA 320A in NSCLC patient and matched healthy control samples. Then to elucidate the clinical pathology impact of microRNA 320A in NSCLC patient. And lastly, to understand mechanism by which how this microRNA is actually impacting the clinical pathological features of NSCLC patient. So for that, we used two techniques like QRT-PCR, immunoblot, immunohistochemistry, migration, and invasion AZ. We found that circulating microRNA 320A was downregulated approximately 5.87, we can say approximately six-fold in NSCLC patient compared to the healthy individuals. Further, we correlated that this downregulation was actually correlated with clinical pathologic characteristics or not. So we segregated the samples and we found that in adenocarcinoma of NSCLC type, there was a large decrease of microRNA, downregulation of microRNA 320A was observed. And when we compare the NSCLC type, NSCLC stages like TNF stage 2 and 3 and 4, we found that the microRNA 320A was significantly downregulated as the tumor increases. So we can say that this microRNA 320A is actually correlated with the tumor progression. Next, we have compared that. I think the slide is very small. Next, we found that the NSCLC patient in smoking condition, when compare the smoking and the non-smokers, because we know that smoking and the alcohol is a common factor which actually causing the lung cancer. So we found that in a smoker, the microRNA 320 expression was mostly downregulated compared to the non-smoker. Same in case of alcoholic condition. Later, sorry, it's the second slide. This I'm explaining the first figure actually. So we further checked that with age, what is the effect of microRNA 320A? So we found that the age below equal to or 50 years of patient showed a most downregulated expression of microRNA 320A. Then we checked for the molecular level that how this clinical microRNA 320A actually targeting this clinical pathology or correlated with the clinical pathologic characteristics. So we checked for the we go for the immunoblot and the immunohistochemistry. So we checked for the anti-apoptotic and the cell proliferation marker. So we found that the cyclin D1. We firstly what we did is to knock out the or silence the expression of microRNA 320A, and on the other hand we mimic the expression of the microRNA 320A.
Uttam, sorry to interrupt you. Uttam?
Yes, ma'am.
Sorry to interrupt you. Can you conclude your results?
A cumulative result. Okay, ma'am. Yeah. The last slide we can say that. The last slide.
Yes.
This is the conclusion part here. What we have done, we have showed that how this microRNA is actually impacting the clinical pathologic characteristics and what the mechanisms involved in all this. So we can see here, this the microRNA is in circulation condition, and we have isolated it, and how this microRNA is actually working on a normal condition. Like it comes and binds with the protein AKT3. When AKT3 it comes and binds with AKT3, it downregulates or it inhibits the expression of AKT3. But in cancerous condition, this microRNA 320A was already in downregulated condition, so it could not bind with the AKT3, and AKT3 was free, and it progresses the cell proliferation and apoptosis and the other metastatic invasion. So here in normal condition, what we can see here, the AKT3 is inhibited. By inhibition of AKT3, the P27 is a tumor suppressor. It is upregulated, and the cyclin D1 is oncogenic. It is downregulated, and thus it inhibits the cell proliferation. But in case of cancerous condition, the mechanism is totally reversed at what we have shown in the previous slide. Similarly, when the AKT3 is inhibited, the BCL2, this anti-apoptotic, is an anti-apoptotic marker protein, which is also inhibited, which further activates the caspase-3, which is a apoptotic one, and thus it activates the apoptosis. But in case of cancerous condition, in non-small cell lung cancer, the mechanism is totally reversed. That's what we have shown in the our previous slide. Similarly, we have also checked for the epithelial to mesenchymal transition. So we checked for the certain markers of epithelial to mesenchymal transition, and we found that AKT3 inhibits the mTOR level, and then it inhibits the beta catenin, and thus it activates the E-cadherin. E-cadherin is epithelial marker, and it inhibits the metastasis. And there's another pathway, this beta catenin act as a transcription factor for the MMP9 transcription, but in normal condition, this beta catenin could not activate the MMP9, and thus it inhibits the migration of the NSCLC cells. So I like to acknowledge ICMR for this project and the DST Inspire, and also the AIIMS Bathinda. Thank you, ma'am.
Thank you, Uttam. Thank you. Any questions from the participants as well as first from the judges, please?
Yeah, Dr. Uttam, that was a very detailed, very lengthy and thoroughly done project.
Yes, ma'am.
And definitely it's difficult to do justice in this poster time to this project. I congratulate you on this tremendous work that you have done. My only question is that why did you choose this microRNA 320?
Okay, the basis of selection microRNA 320A was we have performed the next generation sequencing.
Okay.
Then only we get the certain candidate molecules. Then we further validated it.
Okay.
And then we found that this microRNA 320A is significantly and most dysregulated microRNA in non-small cell lung cancer. That's why we chose this microRNA 320A.
So similar studies in literature have found any relation with the smokers, and you have not found or something like that?
We found that with the smokers, we have found that association.
Okay, you have found a significant association?
Yeah, yes, ma'am. Yes, we have found a significant association.
Okay, very nice study. Thank you so much.
Thank you, ma'am.
Rana, ma'am, would you like to ask?
Yeah, it's a very good study, and it's also innovative. I just want to ask from where the patients were deputed for this study?
The patient was recruited from the AIIMS Simla.
Okay.
Yep.
Thank you.
Thank you,
Dr. Shergill, Dr. Sanjay, please.
just try to penetrate him from this study. It's an extensive topic which is covered in this poster.
Sorry, sir. The voice is not clearly audible. Hello, the voice is not clearly audible, sir.
Dr. Sanjay, would you like to ask anything? Okay. Any question for the participants? Okay, as there is no more question, sorry Uttam, I have interrupted you many a times because I think it's a very nice study. Thank you very much.
Thank you.
Shama, please move on to last poster presentation, poster number 9. And I want to convey to the judges that for this poster there will be no numbering for this poster. Diksha, you can present. A question can be asked. Yes, Diksha. Diksha, are you there? Diksha, are you there? Diksha, please summarize your poster.
Dr. Diksha, can you hear us? Please type in the chat box and let us know.
Yes, sir.
Yeah. Okay. Now we can hear you, Dr. Diksha. Dr. Diksha, please unmute yourself and please speak. Dr. Diksha.
Hello. 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 Oh, yeah. Hello. Hello.
Dr. Diksha, we can hear you. You speak, please.
Hello.
Please
Dr.
go ahead.
Diksha, we can hear you. You please
Hello.
go on.
Hello.
Yes.
Hello.
Now I request all the judges, Dr. Jaswinder ma'am, thank you very much for your time, sparing your precious time and judging our aspirant participants. And Dr. Shedil, thank you very much. And special thanks, Dr. Anuradha, you have spared time and you have missed something for us. So thank you very much. Dr. Sanjay, thank you very much for your cooperation I thank all the speakers from my bottom of my heart, all the judges. Thank you very much, and I request you to send the results on my WhatsApp number. Please share the results.
Thank you. Thanks, Dr. Manjit. I'll just WhatsApp the marks to you. Okay. Thank you. Thank
Okay,
you.
ma'am.
Thanks. Thank you.
Thank you,
Dr.
ma'am. Thank
Manjit.
you.
Thank you, Dr. Manjit. It was very well organized, CME.
Thank you,
We have
ma'am.
already
Thank
had
you.
posters. Thank you.
Thank you. Thank you. Yes, Dr. Diksha, you can present. Please start. Our participants are waiting for you. Okay, Shama, I think Dr. Disha couldn't connect herself. So we'll move on to further our session. And now we'll prepare results. And after 10 minutes, so we'll announce the results. And in the meantime, Dr. Shama, you can present your portal. Over to
Sure, ma'am. Sure, ma'am. Yeah.
Thank you.
So thank you, everyone. And moving further, we have a short presentation from Mr. Varun of Mindray, India. So I welcome Mr. Varun on board.
Hello, everyone, and very good afternoon to all the faculty. I'm Varun Sharma from Mindray, and I will be showcasing a small presentation and a video which shows that what we do when it comes to diagnostic science and how we do. So,
Mumbai, India, a land of many faces. It's the bustling markets of Delhi, the thriving streets of Mumbai, and high-tech powerhouses of Bengaluru. It's feeling the beat of different pulses and the harmony of different sounds. It's where trust is placed in a critical moment with our life support. It's where reliable data are transformed into discovery with our IVD solutions. It's where intelligent inventions save lives with our imaging technology. And where healthcare is advancing with more possibilities. It's the trust in your partner that makes history, whether big or small. As your trusted partner, together we will reach the summit and watch the sky glow. Together we will build a healthier Bharat. Mindray, healthcare within reach.
so this was a small video, what we do. I will share a small presentation as well. Please be with us. So as we showcased in our earlier video that we are trusted partner for Healthier Bharat. And this we have achieved after a long time by hard work and doing some scientific research as well. So our vision since inception has been better healthcare for all. And to achieve that, what we have been doing is to advance the medical technologies to make healthcare more accessible so that everyone who is part of our healthcare system has access to the advanced medical technologies. How we do it? We do it by investing constantly in our research and development, because of which we have 8 R&D centers worldwide. We have more than 2,500 R&D personnel. We invest almost 10% of our annual revenue into R&D every year, because of which we have more than 5,000 patent applications and 15% of patents are recognized in the US. And by doing all this, we have maintained a score of 7 to 12 new products every year. And to do that, we always collaborate with innovative partners to include innovative technologies, cutting edge technologies, so that whatever products we build are trustworthy. They do what they are designed for. As we already mentioned, that 10% of sales revenue goes to R&D. Our R&D has more than 2,500 people, out of which 65% are masters and above. Since innovation has been history of our future, whatever we are now, there is a long history behind that, and that started in 1991. If you look at this screen, you will find that we started with a black and white ultrasound, pulse oximeter, and now what not we are able to offer. We have patient monitors, we have anesthesia equipments, we have ventilators, we have imaging equipments, we have in IVD, hematology, biochemistry, immunoassay, and whatnot. To do that, to manufacture that, we have more than 300,000 square meter of manufacturing space. We have 29,000 plus characteristics for product configuration. We have more than 300 product model across all three verticals wherein we operate. We have solutions for entire hospital. So if you look at a hospital and you look at different segments, we have products for emergency room, we have products for laboratory, imaging solutions for OBG department, induction room, cardiology center, radiology department, general ward, and whatnot. So we are a holistic solution provider. In that, we have three separate verticals: patient monitoring and life support systems, wherein we have patient monitors, anesthesia, ventilators, infusion pumps, surgical lights, in vitro diagnostics that encompasses hematology analyzer, chemistry, CLIA, coagulation, microorganism analysis system, urine analysis system, flow cytometry. And in medical imaging, we have black and white handheld to portable black color and very advanced regional systems in medical imaging. And we have been always striving to deliver the highest standard of patient safety and satisfaction across the segment. And by doing that, we have been able to enhance the clinical decision making in imaging segment. In vitro, we have been able to provide reliable results, efficient workflow by providing modular systems and robust operating systems. Our professional service team is involved at every step. We have more than 20 plus service centers across different countries, 80 plus customer service sites, 240 field engineers, 100 plus customer service sites, and 24/7 hotlines operating in India, China, US, Russia, and France. So not only we are here to manufacture good products and sell them, we are also there to ensure that they are utilized at their optimum strength, and the end user is able to obtain the optimum output from the instruments. Even in this pandemic time, when going was very tough, we had a lockdown at different levels and people were scared to go out, but our support team, including application and service team, has been at the forefront, not only solving the queries from the customer. We have been also installing the new equipment so that the mankind, the patient, can be served at the best. We have been ensured that our productivity, our logistics, speed, everything was in control, and we ensured that the logistics were covered at various levels. So we were able to give wide coverage with reliability and predictability that by when this instrument can be delivered. We also engage with our healthcare professionals at various levels, including the training and development. So we do conduct a lot of CMEs and training workshops, so that biotech people from service department, biotechnology department, we can collaborate with them, and we keep on updating them with the newer aspects of technology coming into the picture. We always ensure that our customers are at the first. So whenever they need any sorts of support in terms of new products delivery, troubleshooting, or the training, we put them to the first. in this pandemic time, when gathering-based events were a challenge, we take proud in saying that we have been doing various online events in collaboration with CII. We have been doing our CUBE event, which is a flagship hematology event internationally, and various other online events. We also do our social responsibility, as in wherever we can, like we did in Amphan relief work when it hit the West Bengal. We did with with AIDS Society and other societies wherever we can do. We have donated for Cyclone Amphan. We have given vehicle support for social cause. We have provided ambulances at Dr. B. Baruah Center in Guwahati. And we have also collaborated with some NGOs who are doing some work for underprivileged children. Thanks a lot for being patient.
Thank you, Varun. Thanks for the cooperation. Yes. Now it's time to announce the results of the posters. Yes. I'm audible? Shama, I'm audible?
Yes, ma'am, we can hear you loud and clear. Please.
Yes, ma'am.
Okay.
We can hear you.
So poster presentations, competitions. First prize goes to poster number 8, Uttam Sharma. Uttam, are you there? First prize is to Uttam Sharma, and second is to two people. Poster number 1 and poster number 2.
Yes, ma'am. Yes, ma'am. I have. Thank you, ma'am.
Yes. Second is to two posters, poster number 1 and poster number 2. Dr. Saurabh and Dr. Prabhat.
Thank you, ma'am.
Thank you, ma'am.
Yes, Dr. Saurabh and Dr. Prabhat.
Yes, thank you, ma'am.
And third is poster number 6, Dr. Sarita. Dr. Sarita, are you there? Third is Dr. Sarita. I congratulate all the winners as well as all the participants. Rest of the participants also, they have arranged, they have prepared the posters at a very short notice, and they have tried to present it very well. Thank you very much. And there is another winner from our MBBS batch class. She's Muskan. Shama, will you please display her photo? Student of MBBS class. Shama, are you listening?
Ma'am, just few seconds. We are on it.
Yes, ma'am. Just a few minutes.
Okay. Take your time. Okay. While I request, while you're arranging it, I request our respected additional medical superintendent, sir, Dr. Satish Gupta. He is head of department of dentistry. He is our.
And here is the picture of
Yes.
Muskan.
Yes.
You can,
She is the winner of the MBBS batch poster competition, Miss Muskan. Many congratulations to Muskan.
Hello.
Yes. Now moving on to further. I request Dr. Satish sir, he is additional medical superintendent of our institution. He is professor and head of Department of Dentistry. He is officiating dean of our institution. So I request Dr. Satish Gupta, please sir, deliver a vote of thanks lecture. Move on to Dr. Satish Gupta, please.
Am I audible?
Yes, sir. Very
good
welcome.
afternoon, everybody. I would like to express my gratitude, first of all, our worthy director, sir, Dr. D.K. Singh, for taking his time to inaugurate this CME. And on behalf of the organizing committee, I would like to express all my thanks first to Dr. Ajit Saxena, AIIMS Patna, Dr. Amanjit Bal, PGI Chandigarh, Dr. Jasinder Kaur Bhatia, Command Hospital, Kolkata, then Dr. Soumya Ranjan Malik, AIIMS, New Delhi. And I would like to congratulate Dr. Manjit and her team who has done all day and night to make it so successful. And I would like to thanks all the participants also. I think they might have taken a lot of they are benefited from this workshop. Thank you so much.
Sir, please stay with us. I request all the participants to unmute switch on your video so that you can take one photograph.
Ma'am, you and Dr. Satish Gupta, can you move a bit away from the bit behind? Yeah, so because we cannot see your faces properly. Yeah, yes.
Now it's okay?
Yes, ma'am. So all the participants, please switch on your videos. Dr. Diksha.
Yes, ma'am.
Also, please shift a bit behind. Yeah, still a bit
Yes,
behind
ma'am.
because half of you are cut. Half of your face is cut.
Yes, ma'am.
Dr. Sanjay, the light, you are against the light. Can you switch on the light because we can't see? It's very dark on your side. Can you switch on the light, Dr. Sanjay Kumar?
It will,
Fine. Yeah, now it's a bit better. Everyone ready? Dr. Diksha, your video stopped.
Yes, ma'am.
Shama, please go ahead.
Yes, sure. Okay, so smile, everyone. One more picture, one more time. One more time, please. Yeah, done.
Thank you, Shama. Thank you. Thank you, sir. Thank you, Dr. Stephen. Thank you, sir. And now, we are ending this ceremony. And thank you all the speakers and participants and judges for sparing your precious time. Thank you very much.
मैम रिफ्रेशमेंट्स ना दे देंगे अच्छा ठीक है अच्छा हुन पा ले ओके